aren't on here.
Yeah.
You guys could just tell him. All right. Now we're live. And we'll go to screen share. Entire screen. All right. I'm using a different computer today too, so that took me a little time to set up. I'm full of excuses tonight. All right, so chapter 10, patient assessment, the primary assessment. So, and this, I think they're going to, looking on there, I thought they said airway, but maybe I was just reading it wrong. So you can look at the objectives on page 242 to see what they are, guys. I'm not going to read those off to you, but I'm going to turn to 242, so we're at least read the case. So, topics 8 components of the primary assessment. I think I just might have said some of them as I was bitching about complaining about national registry. Sorry about that. So, after the scene size up, and the most important part of patient care. So the call, you're the emergency medical responder called to assist a 36-year-old male who has cut his leg badly with a chainsaw while cutting trees. You arrive to find him seated with his leg wrapped in a blood-soaked t-shirt. There's a great deal of blood on the ground. As you approach him, he calls out to you for help. So discussion, there are several immediate concerns for this patient. How should you begin your assessment? So remember, dispatch for a 36-year-old male, badly cut his leg with a chainsaw, seated with his leg wrapped in a blood-soaked shirt and a great deal of blood on the ground. So what do you notice right away? I want some things that you guys noticed right away. Has anybody read the chapter yet?
Chapter 10?
Yeah. You guys have
started this definition.
All right. So the ones that have read it, I'm just joking, guys. So for the ones who have read it, what are some, and everybody for that matter, what are some important things we're looking at as we're walking up on this guy?
He's got a lot of blood drawn that we
Okay.
get something.
So for you, and I haven't even read the chapter because I'm a horrible instructor, but in the book there's something about what's that? Yeah, okay. So you got your general impression. But do you think you have maybe a life-threatening bleed here that we need to address right away? And what you guys will notice, and what he's talking about, is your general impression. So obviously, gloves on, scene safe, right? We want to make sure that this guy isn't a chainsaw-wielding psycho like on the Texas Chainsaw Massacre, right? And apparently he's not because he's sitting on the ground. But your general impression, you are going to develop that. So what is your general impression of this guy?
His consciousness, he's conscious and asking for help.
Okay. Your general impression is what you think happened here. So you guys, general impression is he cut his leg with a chainsaw, right? So do we need additional resources in this situation? Yeah. Because we're EMR right now, right? We're just first responders. So we're going to go ahead and probably request possibly ALS in this situation. Do we really need anybody else? I mean, we could probably handle this guy, right? We all know how to shut off a chainsaw or move it, right? So we don't have to have fire guys there. Now, if he's a big dude, you might need him to lift, or if maybe a tree is obstructing your ability to get to him.
If it's easy to get him out or not.
Yeah, exactly.
And wherever all the trees are at.
So so your general impression, his level of consciousness, what is he?
He's awake.
He's awake. That's good, right? Okay, so his airway. As you're walking up, his airway.
Listen how he's talking to you.
Yeah, it's patent, right? It's open because he's talking to you. Breathing, obviously, if he's talking to you, he's breathing. Circulation, obviously, he has circulation.
Circulation because he's losing a lot of blood.
Disability. We have that laceration to the leg, right?
Right.
Exposed and update incoming EMS. You do have a possible life-threatening injury here. What would we do if we walked up and he wasn't not breathing or no pulse?
Firstly, you find out where it's at. where he's cut out on his leg, you're gonna have to put a tourniquet, because if you start doing
Okay.
CPR, all you're gonna be doing is pumping blood out.
Okay, let's throw out the whole chainsaw thing out. We're just gonna say, well, just walk up on him. He's sitting against a tree and pulls a snap. We're gonna go ahead and check and make sure that he's not rotten, right? And then probably go ahead and as we go down these steps, as we get to airway, breathing and circulation, they're not there. We're gonna try to restore those. See, HA used to teach kind of the same method. The ABCs, fix it as you find it. These are the most important things: airway, breathing, and circulation. Without airway, breathing, and circulation, you don't have a patient, right? So you need to either restore those with compressions and ventilations. Well, that's about the only way you can restore those. After that, you have this deformity or life-threatening injuries, which is your laceration. So what are you going to? You said that you're right on it. What do you want to do for this leg?
I'd put a tourniquet on it to stop the bleeding, and go ahead and start compressions and ventilation.
Yeah, you don't have to worry about it because he's talking to you, right? We're going to go back to this normal scenario. Sorry about that. So we have this life-threatening bleeding. We're going to address that, correct? Because what's going to happen if we don't address that? Yeah, he's going to bleed out. Then we're going to have to be dealing with the ABC part of it. So, all right, good job, guys. So 8 components of the primary assessment: the general impression, the patient's appearance, obvious life threats, patient's condition, and chief complaint. So our patient appearance, right now we're looking at him. They didn't tell us what his appearance was, but if he's talking to us, he probably still has decent mentation. So, any obvious life threats? Our chainsaw guy, his obvious life threat is this deep cut in his leg. Patient's condition. What condition would you say this patient's in?
He's probably having chest pains.
Well, not this one. Let's stay with our chainsaw guy. That's a totally different guy. I'm going to tell you something about this picture here in a minute.
So the general impression of the chainsaw guy.
Yeah, what do you think his condition is?
It's probably pretty grim.
Yeah, it's pretty serious. I don't know about grim. We're gonna put a tourniquet on it and they're gonna fix it. He'll be good to go. You don't even need legs. They make these things. They're called spring. I call them springy legs. I don't know what they're called. They look like curves. He'll be able to run in the Olympics before you know it. So his patient condition is you have a patient that's in serious condition, so rapid transport is going to be needed, and his chief complaint is pain to his leg. See this guy right here? I forget what that sign is called, and I always forget it. But see how he has a fist? Mm-hmm. That fist is indicative of actual cardiac chest pain. What would you normally do if you're having chest pain? I'm having pain right in here, right? Mm-hmm. If somebody's and Lee, if you guys can't see me, I'm going to do what this guy does, but I'm having pain right in here. They make that fist and they're explaining that pain in that chest area, that left side, left center of the chest. Guys, start thinking this guy might be having it. It's a pretty good chance this guy's having a heart attack. And I forget what this sign is. If anybody wants to Google, I don't think it's Levine's sign. I forget what it's called, but it's making a fist whenever you're describing your chest pain. There's actually a name for it. So anyway, all right. So the general impression, how the patient looks to you as you approach. Chief complaint, the patient's response to your questions about how he is feeling or what is wrong. It's what they complain of. Okay, even though they might be having a heart attack, their chief complaint may be shortness of breath. Okay, so that was what you report as their chief complaint. So we have consider the following: a patient at the mall trips getting off of the escalator. She is awake and holding her ankle. So scene size up consideration. Are there any hazards from the escalator? Did she fall from the last step from the top? Is her ankle injury open or bleeding? Let's say that it is open. But it's not bleeding heavily. Is that a life-threatening situation? Not at this time, it's not, right? So be aware of that. Sometimes we have what I guess the industry calls distracting injuries. let's say that she got dizzy, tripped on the escalator, broke her ankle. She has an open fracture to the ankle. But the real question is, why did she become dizzy? All right. So we get distracted by this ankle. We treat the ankle just to find out that her blood sugar is 24, or she's having a cardiac, she's an older lady and she's having a cardiac event. So always find out the whole story. Try not to get tunnel vision. Try not to let the gruesome injuries distract you from going ahead and find, let's say, car wreck. You find this, you stop there, but don't stop there. Try to find other injuries. You might have, let's say that you do have a car wreck. You have this open fracture, and you stop there. You start treating it. Yet you didn't expose, and now you didn't see the abdomen, and the abdomen is bruised all the way across. So now we're looking at, possible lacerated liver, possible lacerated spleen. At a minimum, we're considering a hot abdomen, right? Because with all the bruising, we're thinking there's the internal bleeding. So which injury is worse here? An open ankle fracture that's not bleeding, or the abdomen that is bruised? Yeah, definitely. So try not to get tunnel vision. Do your full patient assessment. So, then here's the next one. Patient falls several stories from the roof of a construction site. Several extremities lie at unnatural angles. He looks unresponsive and blood coming from his mouth. Wow. Okay, that's going to be a pretty gruesome scene, right? At a minimum, you guys are going to be causing this guy a lot of pain to get him packaged up. All those extremities at unnatural angles, getting that person on a spine board is no fun. But what are we more worried about here? Yeah, internal, right? So the mechanism of injury is significant. You will have to take standard precautions of at least gloves and eye face protection because of blood in the mouth. Make sure that there is no risk from falling objects or other construction hazards or other construction workers falling on your head. Will additional assistance be required to extricate the patient or move him to ambulance? Yes. Possibly, yeah. So primary assessment observations. The patient does not appear to be responsive. He may have a spine injury and will require cervical spine immobilization. He will require airway care, including opening, suction, and possible ventilation. Notice that in that primary assessment observations that they really didn't dwell on those angulated extremities, did they? No, we're talking more about securing this airway and C-spine precautions than we really are those angulated extremities. So anyway, moving on. Do you guys, is there water in? Can I get one of those waters by any chance? So for your general impression, here's some serious signs. Unresponsive or altered mental status, AMS. Don't call AMS, call it altered mental status. If you just wrote a patient was AMS, had AMS in your chart, I'd ask you what AMS was because I have no idea. Whenever I first got into this business, and even for probably the last 15 years, EMS has been using a lot of abbreviations. Then whenever I got into it, we had our own set of abbreviations. But shortly after I got into it, we went to medically approved abbreviations. So we only use abbreviations that hospitals and things like that would be familiar with. And now you're seeing another shift to just doing away with abbreviations altogether. They find it doesn't really save you all that much time while writing your report, and it reduces confusion if you don't use them. So anybody that reads that chart knows what you're talking about. I highly recommend you don't rely on abbreviations. If you already do, that's something you already do. I'm not going to tell you you're wrong, okay? Jacinda, how's the nursing world doing that? Are you guys kind of moving away from abbreviations, or you guys still use a lot of them?
We have ones that are approved by the hospital, but I don't think anyone really uses them.
So most people are moving away from them there too?
Yeah.
Yeah. And I think it's great. Kind of like on your guys' 10 codes. Also, it's all, most everybody that is in here is either related with the fire department, police department, or something like that. 10 codes on a national scale are not recommended to be used. Thank you. Why is that? For you guys that have had the NIMS, do you guys know why they're not recommending 10 codes?
They're different from different agencies?
Yeah.
Like, ours are different from Wheeler's.
Yep, definitely. There it is. Thank you for that answer.
I mean,
10,
ours are different than LC's.
Yep. 10 codes, no matter where you go, means something different. So somebody that thinks I made the mistake. I won't put it on anybody else. I made the mistake of thinking that 10 codes were common language, and I started working on 2 different ambulance services, and I got a awakening. Topeka and Wichita don't use the same 10 codes. So whenever NEMS came out, they highly recommend going away from 10 codes, because whenever you do interagency things, it gets confusing. So
We've actually talked about doing away and going straight talk.
it's hard to do that. So it's hard to change that culture, because you get so used to using 10 codes. I find myself, I have to think about what the heck I even want to say. Like, are we back out at the barn, or are we back out at our station? What is this thing here? Rather than just using the 10 code for it. So, but anyway, serious signs: unresponsive or AMS, anxious, agitated, or sleepy, cool, sweaty skin, position indicating chest pain or difficulty breathing, severe pain, severe hemorrhage. So those are possible serious signs possible serious signs. So not serious signs. So if you come to a patient, they're awake and alert, they're not anxious, they're talking to you. Yeah, we probably hit going 5 miles an hour. That's not a serious sign, right? No apparent difficulty breathing or chest pain, normal skin color and condition, and relaxed appearance. So guys, be very aware of an anxious patient. Are they anxious because they have this adrenaline rush from this rollover accident they just had? Or are they anxious because the body's shifting its resources more internally to take care of the internal organs, and so now they're becoming anxious? They're getting starved for that oxygen. So kind of pay attention to your patients. If you get that anxious patient, sometimes that's your very first sign that they're not doing all that great. Okay, so level of consciousness, guys, you will want to get to know the AVPU scale. Stands for alert, verbal, painful, and unresponsive. Okay, you will want to know that, I promise. So alert patient, we're all for the most part alert in here. I don't see anybody asleep yet. I wouldn't blame you if you were. If you were, and I said, "Hey, Joseph, wake up over there in the corner," and you wake up, you're alert to verbal stimuli. Okay, I was able to wake him up. Now, if I have to go over there and I have to tip his chair over and rub on his sternum a little bit, and then he wakes up, then he's responsive to painful stimuli. Okay, and if I can't wake him up, no matter what I do, he's unresponsive. All right, pretty self-explanatory, right? Remember it. It's the AVPU scale. You will use it forever. Dun dun dun. Just trying to see what. Let's see. Did anybody take any time to look that up? That I don't. Oh man, I hate it whenever my deodorant lid comes off and deodorant breaks all over the place. That's terrible. Jeez. Okay.
It's too hot outside.
Yeah, oh, that's terrible too. My battery's low. Okay, so all right. I saw that guy again sitting there with his. So they have a pretty good. They have a pretty good little chart here, patient assessment of your primary survey. So you have the AVPU scale, then you're checking airway, all right, breathing, and circulation. It kind of gives you an action to do for each. So patient is responsive. You don't suspect trauma. Open the airway using head tilt chin lift maneuver. If spine injury is suspected, use jaw thrust maneuver. Patient responsive, trauma is suspected and spine injury is possible. If trauma is suspected, use jaw thrust maneuver to open the airway, right? So now we're not worried about the head tilt, chin lift, or whatever. And then patients vomited all over himself. That's disgusting. So it's on page 249 for you guys that are flipping through your book. So all right. So airway. Whenever we assess an airway, is the airway patent? Does everybody know what patent means? Yeah, it's open. It's going to remain open, right? It's a patent airway. It's not obstructed in any way by the tongue, by a foreign object. That's a patent. A patent airway is an open airway. If the airway is not patent, what are we going to do? We're going to open that airway, right? Head tilt, chin lift, or jaw thrust maneuver. So if it is not open, the airway, open the airway and maintain it. A position patient, open using head tilt or head tilt chin lift. Use jaw thrust if you suspect spine injury. Insert oral pharyngeal airway and clear any obstructions. Okay. Understand that there may become a time where you can't just easily clear an obstruction. What are you guys going to do if you do find an obstructed airway that you can't clear? You're going to do this all the same steps as CPR, beginning with if they're unresponsive, right? You're going to try to get that airway clear. Definitely get ALS in their way because we have laryngoscope and McGill forceps. We'll just pull it out. So breathing, adequate breathing. If the breathing's adequate, they don't show signs of hypoxia. Or so you have adequate breathing, signs of hypoxia, agonal breathing, and ventilate if indicated. So what is an adequate ventilation? What's the adequate breathing rate? Anybody?
For an adult?
What's that?
For an adult?
Yeah, for an adult. Sorry about that.
18.
Yeah, 12 to 20. So you have a range there. What are some signs of hypoxia?
Having trouble speaking.
Okay,
Many
yeah.
words and they have to take a breath.
Yeah.
Low, damn it. I missed this one
Blood
too.
sugar and low blood pressure. I thought.
Well, a sign of hypoxia. One of them we talked about. Right when they start becoming hypoxic,
Oh, they're grayish.
yeah, and they start to become anxious. All right. Some other things are altered LOC. Yes, you do have the cyanosis around the lips, but if any of those things could be signs that they're becoming hypoxic. Right. What is agonal breathing?
That's low or infrequent. Yeah.
Very infrequent, right? You're looking at about, we called it guppy breathing, one of the previous classes, and then ventilate if indicated. So basically everything below adequate breathing, if they have signs of hypoxia, there was a chart in there, I think there was how you begin. So you start with, let's say it's mild difficulty breathing or mild hypoxia. You can start with a nasal cannula or non-rebreather mask. And you could work all the way up to a back valve mask for that patient that is either breathing shallow and rapid or shallow and slow. So basically, if you have somebody that has altered LOC, you're going to look at going ahead and bagging that patient. So circulation, pulse rate, and quality. You want a nice, strong, regular pulse. You don't necessarily want it bounding, but you also don't want what they call a thready, where you're like, just feels, it feels small under your fingers, I guess. Bleeding, is there any signs of bleeding, or for our primary survey, are there any signs of serious bleeding? Just a small laceration that's not really bleeding, all that isn't that big of a deal. Yes, we'll take care of it, but it's not something that we're going to stop doing our primary survey to do. Now, if we have blood spurting or a large amount of blood, we're going to take care of that right now, right? And then skin condition. Real common thing, most everybody sitting in here is warm, pink, and dry. You want to note if any changes. They look pale. Do they look gray? Do they look cyanotic? Some skin conditions can be hot, moist, or also you have the diaphoretic patient, a patient that looks like they've been mowing the lawn, but they've been sitting in a recliner, right? That's a patient that they're sweating a lot, the diaphoretic patient. So disability, you have the APU scale, so alert, verbal, painful, and unresponsive. Movement of extremities and then sensations. Let me see. So I'm just kind of looking to see what we got here. So the disability check uses primarily in trauma patients, is designed to test the central nervous system, the brain and spinal cord. When the central nervous system is injured, the body usually has serious and predictable consequences. The patient's mental status is one of the most significant indicators of central nervous system function. You have already done a determination using the APU scale of responsiveness. As you continue to examine the patient, what's that? Oh. If his eyes open spontaneously upon stimulus or not at all. Does the patient speak? If so, does his speech make sense, or is he confused or unintelligible? So, all right. So the response, let's see. We have that bleeding is controlled. So the ambulance arrives on scene. You have only been able to complete the primary assessment and didn't get to the history, blood pressure, any further examination. You update the EMS unit. So the response, your bleeding is controlled. You continue your assessment. Patient is anxious and pale. His pulse rate is 128 beats per minute. Well, I thought this thing just said we didn't get that. So whatever. So 128 beats per minute. Is that a normal heart rate? That's high. Or what's another word for a heart rate that's high? Tachycardia. Good job, Joseph. Not hypercardia, right? Tachycardia. Good job. So, what is this a sign of? Do you guys think and why? Let's say number one, what is this a sign of? And number two, why is it going this fast? Let's think about what's going on here. We have this big cut, a lot of blood. What's the blood do?
It comes oxygen.
Yeah, it carries oxygen, right? So what does your body want? What does your muscles and your organs want? Yeah, because what does it want out of that blood?
Oxygen.
It wants that oxygen, right? So
It's probably because it's overcompensating for where he's bleeding.
I wouldn't say overcompensating, but compensating would be a good word here. We have
It's
the
bleeding somewhere, and it's got to fill it back up.
and so why are we going fast though?
Right.
Yeah, because it wants that, and so since there's less of the blood there, it's pumping faster. So it's trying to get that oxygen to the body, right? I could almost guarantee you that if his heart rate's 128, he's also breathing faster, right? Chances are, I don't know, we haven't got a blood pressure, but because you use this word that I really like that you use, which is compensating. Let's just say that he's in compensated shock. This is beyond this chapter. I'm not even sure we'll get into that. But what would you expect to see his blood pressure if I told you his compensated shock?
It's going to be high, isn't it?
It's going to be normal. Why is it normal? But no, you're good there. Why is it going to be there? Because we're compensating. Once that blood pressure starts to drop, it's a pretty bad sign, okay? Let's say that you get there and so you have your stages of shock. First is your compensated shock. You're going to have increased heart rate, increased respirations. Blood pressure is going to be normal, possibly normal to high. As you go along, more blood goes out. You start to go into decompensated shock. How do we know that we've gone into decompensated shock? because our blood pressure starts to drop. Okay, we drop below that 100. No longer are we able to maintain that higher blood pressure. That's important because you have to have a high enough blood pressure to pump this blood to the organs. At a certain point, which is right around the low 80s to mid to high 70s, you start to shut down perfusion to organs like your kidneys and things like that. And so that's a bad deal, right? Because now we're gonna have indoor, trying to keep the brain and the heart alive. Good job. And so you're gonna end up with end organ failure. And so even if we do save them, they're gonna spend a lot of time trying to fix a whole bunch of other problems, right? So guys, I took you way beyond what I think this chapter wants to, but I want you guys to start thinking of your patients like this. Even if it's not required of you to think of it like, or not, it's not required for you to think like this as an EMR, you need to, okay? You need to think, why is this happening? Why is the heart rate 128 beats per minute after he lost all this blood, okay?
Well, now, with the chainsaw guy, would he be going through the same thing after a while, or could he have, by the time we got out there to him, it already started to level out?
So yeah, this is our chainsaw guy. So let's say that we do have 128 beats per minute. At a certain blood loss volume, I believe it's 2 liters. Don't get me lying to you. It might be a little bit more. He's going to start. His blood pressure is going to come back down. Thing is, it's not going to just kind of come back and level down. It's going to it's going to start going down. Now, if we put this tourniquet on him, his heart rate's 128. We're probably going to keep it there, okay? And the blood pressure's good. We stop this bleeding. There's a good chance that we're going to be able to keep it up there. Okay, he's going to need blood. So who do you know? Guys know anybody that carries blood around here?
The hospital.
Arivac actually does now. Arivac carries O negative blood. So they could get on scene, they could see this patient, they could call, they could get an order. I'm not sure what their blood protocols are, but they could go ahead and get this guy blood if he needs it. That's great. He needs blood, and then he needs surgery, right? So, all right.
I remember it in that cool class. Yeah, I remember that when they was over here.
So primary assessment, ABC may be performed in any order based on patient's injuries and priorities. So that circulation may come first, right? He's talking to us. But what do we do if he's talking to us?
You start asking questions.
Well, we already saw that A and B are intact right now. I mean, right? We don't have to, guys, and this is, okay, I'm going to tell you this for whenever you become an EMR, not for National Registry. As you walk up and talking to him, you've already identified that airway and breathing are intact. Do not skip those on your National Registry test sheets. You're still going to go back and you're still going to verbalize, or you're going to assess his airway and breathing, even though that you know because you're talking to him that they're intact, okay? Understand that. But let's say, Bill, let's say that we walk up on him, you see all this blood, and he's unresponsive. Okay, not breathing all that great. Which one do you think we're going to do first?
I'm going to check his breathing first.
Okay, but we're probably going to take kind of what you told me earlier what you're going to do, which was you want to put that tourniquet on because why? Because if you don't, yeah, you're just going to
pump it out.
Yeah, why is he in this situation?
Probably because the blood that he's lost, he's already unconscious.
Yeah, all this blood that's lost. So we don't want to lose any more. So we're going to take care of that C first, right? That circulation or that deformity. All right. Expose. And this is kind of, I talked about this a little bit already. The don't get tunnel vision by that fractured ankle. You can see that distracting injury. You have that open ankle injury. It's not really bleeding. It's not really all that serious, guys. It hurts like hell for that patient. It hurts when you move them and you feel bad for them. And it actually kind of gives you the queasy stomach whenever you hear them bone ends rubbing together. But let's say that they're in a car wreck, they have a hot abdomen, and you got distracted by that ankle, and you didn't expose that abdomen, you can't see it, right? So we need to expose. So priority updating incoming EMS. Update EMS units with patient condition. Guys, I don't want you, I personally wouldn't want you to call me and tell me everything you find, okay? Now, with that being said, you guys find some things, you get a blood pressure and all this, you might call me and give me an update. Hey, incoming unit, you have a 28-year-old male patient. He has cut his leg with a chainsaw. We've gone ahead and put a tourniquet on him, stop the bleeding, current heart rate. He is alert. He is talking to us. Blood pressure is this. Heart rate's that. Do you guys have any questions? Man, that'd be awesome information for me. Awesome. They put a tourniquet on. I know what I'm coming into. I even got a nice little set of vitals. I don't need things like allergies and medications over the radio. I can get that whenever I get there. You guys write it down, hand it to me.
What about an emergency bracelet or something like that?
Check a med alert.
Right.
Yeah, it'd be great. But it's really something that I'm not going to need as an incoming until I get there. Now, once I get there, you're like, hey, we found this med alert tag, or he told us he's allergic to latex. I'm going to take some latex precautions. So. Is he still working on his test? You shouldn't wait till class time. He's fired. So, all right.
What do you do on that if they're allergic?
Most of our stuff on ambulances now is latex free. You had this latex used to be used in everything. It's still in some stuff, but you just try your best not to use it to have a latex allergy. So, other pertinent information: patient's age and sex, chief complaint, level of consciousness, pertinent findings regarding airway, breathing, circulation. All right. I don't need your allergies, medications, and things like that. You know what? Unless you're on a medical call and he has a history of cardiac, he says it feels like a heart attack in the past. That'd be great information to have. Oh, we're going into the cardiac chest pain. So, EMS 24, we are on scene with a 24-year-old female patient who was a driver in a motor vehicle collision. She is in the car and complains of neck pain. Her ABCs are good. She has sensation and movement in all extremities. We're stabilizing her C-spine and continuing the assessment. She is the only patient in the crash. That's great. He told me that she's the only patient in the crash. So now I know that either I can handle it or one helicopter can handle it. So that's all good information. All right. Trying to see where we're at here. We're almost done with this chapter is where we're at. So, transition. EMS arrives on scene. You were only able to complete the primary assessment. You update the EMS personnel. Good for you. Do you think the incoming EMS units will be upset because you only did a primary assessment? Would you tell the incoming EMS units the patient was stable or unstable? You think we're gonna get mad at you if you didn't do it?
No.
I'll be honest with you, because I feel guilty at times too. Whenever I call air, sometimes I just made patient contact and they're landing. I didn't get a whole lot done. Okay, just let us know. Hey guys, we just got on scene 3 minutes ago. This is what we had. Sorry we didn't call you with update. It's not gonna hurt my feeling. I'm gonna be like, cool. You know what? As a matter of fact, I'm not even going to say anything to you if you said, yeah, we've been here for 20 minutes and we didn't really get information. I'm just going to be like, them guys are idiots, and I'm just going to go off my business. I'm not one unless you're doing something dangerous that I'm going to make strife with you. I mean, you're out trying to do a good job. I might talk to you a little bit later because I know you guys. Hey, why were you on scene and not, didn't get anything done? But I'm not one that gets upset and throws temper tantrum. I think those people are silly. So I do get a little tense with my partner or my crews whenever we're running critical patient. Not because I'm upset with them. It's because I wanted all this done 10 minutes ago. And we've only been.
We used to do some of that when Eugene was here. And you can have that stuff broke down or give it to them. They don't even look at it.
Yeah,
You
that's,
could tell them and they just totally ignore you, so we kind of got out of the habit of doing it.
yeah, that's not right. I mean, I could talk about medics all day long. I mean, there's unfortunately, there's all different types of medics out there. And I'm not going to say that I'm always the easiest
We
person
have
on
now
scene
a
either.
lot better. I mean, the ones that I've dealt with down here now.
Yeah.
They're hands down way better than what we did.
Yeah, that's good. I try to work with everybody, but I'm not going to say that I don't ever jump ass, because I will. So
I've had about enough of them too.
That's how Oak City does us now.
they're just,
They don't give a shit. I mean, we can start giving them a patient update,
yeah.
tell them what's going on since we got there. They could really.
Yeah, they don't care about
Their
name,
deal is-
age.
Their deal is get the hell out of our scene.
Yep, get out of our scene. It's our scene now. You get out of the way.
Wow.
And I've already addressed the 911 or the 522 board with that. And Pat told me I need to shut up my own fucking business. And I told him, I said, okay, I said, so next time you come to Sarah, and one of your EMS people get shitty and sideways and start just handling the patient again, I said, I'll just have the officer put him in handcuffs and take him to jail for abuse. How about that? And he says, you can't do that. I said, yes, I can. And yes, I will.
Yeah,
It's turned into a big pissing contest.
yeah,
Last month.
I'm not into the
They're getting way too big for their goddamn britches.
pissing contest. I like trying to get along with everybody. Now, them folks over at Leedy, I mean, gosh, I don't know if I can't really, just kidding, guys. So, I actually enjoy hanging out with Leedy every once in a while. They're good people. So. What's that?
Come hang out over there.
Anyway, define the following terms, general impression. So somebody threw out what general impression is.
Your impression of the patient as you're walking out.
Yeah. So somebody threw out what chief complaint is.
What the patient complaining of.
Yeah, good job. What the patient complains of, right? That's an important term. What the patient complains of. So, level of consciousness. Give me your levels.
Awake,
Alert.
alert,
Verbal.
verbal,
Pain. And a response.
Understand. Good job, Avku. Good job. Patent. Give me what a patent airway is.
open airway.
An open airway. And agonal respirations. Yeah, irregular, infrequent gasping of breath. So, all right, good job, guys. Here, we'll go ahead and do these and see if we could. The mnemonic for remembering the level of consciousness is, AVPU. Good job. The patient who responds only to a pinch to the muscle near the neck is said to be responsive to pain. Yeah, good job. Easy peasy, right? The general impression is best described as
How the patient looks as you approach.
how the patient looks as you approach. So, all right. So discuss signs and signs that may indicate the patient is in serious condition. Remember, they had that list there. You guys remember what that was?
Non-responsive or altered mental status.
I would highlight these. What page is that?
247.
247. Guys, I would highlight those because I can almost assure you that these will be on the test. So, position indicating chest pain or difficulty breathing, severe pain, and then severe hemorrhage. So that list on 247, I would know that. What are abnormal findings when assessing circulation? Yeah, no pulse, patient with weak or absent radial pulse, and pale, cool, moist skin. And then discuss signs of inadequate breathing. gasping. Let's see if we could find, there should be a list on that.
This would be, gurgling sounds.
Snoring.
Yeah, all those, and then guys, there's the breathing, it's a whole big paragraph. So it's on page 254. I would definitely know what the signs, of inadequate breathing are, okay? So. All right, let's see, it is 7:10. I probably kept you guys as enthralled as I can for a little bit. Go ahead and take let's just go ahead and do a 15-minute break. Come back and hit another chapter. Cool, you guys? Any questions on, let's be back at, just after 7, let's just make it 7:30. Easy enough. Give everybody a chance to go out and smoke their cancer sticks and chew their dip and all that other fun stuff.
Kick out.
Seven 7:30, lady, come back.
Okay, we'll see.
But it didn't have that. Yeah, where did you say it? I said it wouldn't go up. There's a bomb. I thought that was up before. And I'm going because it's adult. But there's a couple of units that I'm pretty sure that you can see this one thing. I don't know if I had them right. Because I don't know what's going to do that. And then I went back and that's what my mindset was. Okay, I'm ready to, okay, yeah, I remember that. I remember that. But it's not even that, like, I didn't roughly like put last first, that key word that makes all the other ones wrong. This first test I've taken in 4 years, so I'm probably just a little anxious to get it over. I took mine on my phone and I was scrolling through to make sure I answered everything there was some in that place because I was scrolling. Because when I accessed my wrong answer, that's what's wrong with this? I didn't put that in there. Because there was one about giving to who you give information to. Giving out. Yeah, the child care or the daycare. Giving out information, and I put, you can give the information to the oncoming paramedics. And it said I put some number. She said, here's the deal. You get the daycare. Child care, no space. And it's not you get I know people that have in-house daycares. That are they covered? You're dealing with compliance. That's right. Yeah, I think one of the answers was go ahead and start rushing it out. You don't get it. Now, parents there, you have
You know how to get this again? He was not that hospital. There's one up here by this. They was on the, I can't remember what side, but.
You ever had to look at the churches where you do what? You ever had to look in the churches where people are stealing from the fire right there?
We had one down.
God's not like, they'll refuse, they'll get treated.
All we do on a case like that, especially when you are coming to a child, is probably is because if they're in imminent danger, DHS can step in and take that child from them and even go against their religion. Of course, it turns up in the courts, it turns into one of those situations, but
I just don't. I mean, I respect people's religions, but when it comes to a life and death with the kid. That kid has no choice.
Right.
That's the parent's choice, not the kid's choice.
So without having that fire after we all even got there, they just moved over.
Just y'all two made it out there, over.
Now, Travis and, Al came on. After we got late.
It's not the DA, you're not dealing with DA. So we do have educating.
So, right then, you know, yeah, so I kind of turned back there, and I said, "Come on, you're going to the money." So I put in the place, I put the turn and walk in, and he rub on you, and that's around each one. Wait a minute! And so I forgot he's big. So I grabbed him and pulled him in, and just, whoa, it's a strong guy. So why are you doing this? And so I'm like, I have no idea. So I'm like, you know, I like this guy, you know, like, you know what? It's like he's big. Yeah, I don't know. You know? Maybe you can shit out of me. And, so the grabbing, like, put it in, and like, no, I'm not this, I'm different. And so I was like, now, if we get one, so I work him over the grass. But I should be getting facial or I go down and I'm knocked out. Go ahead, Rick. So I just roll over into the wall and just. And also, sinks it in deep. I mean, well, this, you want to get my ass with. Yeah, and so. Great, you always told me I don't understand. You never fucking lie. So I just lay there and I started bleeding all over the arm and stuff. And those were my twins out there. Get through stuff. And he showed me, well, his heart would beat the shit out of me. And so he kind of he loosened off and he was getting more for it. We just grabbing out. I was like, yeah. And you know, started swimming. And finally, he came out and pushed him off. And so that was the first time that I started up with him. I think I did. And I think my teeth all offset. And people showed they thought he fractured his jaw. And so I squared up with him. And, you know, it's so confused why you did the same thing. So he goes, "So you tell everybody I left my wife, and I left my wife." And I don't remember if that was, you know, like, kidding. And I just kind of look at it, and he's confused, because they filed for divorce and and so he gets in the car and he, stuff, and anyway, kind of proves all the time. Yeah, he's thinking it's really young. I don't know, you know, I'll tell you what he captured here in a minute. So, anyway, Bruce talked to him, and he said that, like, I don't know, kind of stuff on they're all awesome. But, so, everything, and, they finally felt themselves, they let me do that, and shit like that. You know, like, when I was talking well, I got to keep here. But that shit was work. He waited over 45 minutes for an act like work.
That's pretty bad task right there. But state of Oklahoma does not have particular statute. We do not have that particular. We have legally person with assault battery, aggravated assault.
No, nothing broken.
Still, the great bodily injury, basically, the great bodily injury is described. Your teeth, that's great bodily injury. The cuts and lacerations, that's great bodily injury.
They're only thing children that was the one that's all on.
But see, that's a simple assault. That's a
But yeah, what about this? Choking?
No, they can say, okay, Oklahoma. Well, I don't, him and I didn't have a previous relationship. So it's just it's a misdemeanor. Now, if him and I had a previous relationship, that would be a problem.
It'd be first degree murder because if I see that something, you get a part of the bullet.
Well, you know what I told him?
It's false, okay, on the same citizen. I would like to see them come up with here's what I'll say what happened. Really riots in prison. I had to sit there and watch hours and hours and hours of film. They had one guy that they didn't beat the shit out of. He was sitting on the ground with his feet sitting up, and the guy stuck behind him with a baseball bat. And I'm not talking this guy teed off on this bed, hit that dude in the back of the head, almost killed him. And he almost died. I'm going to look for assault and battery and then
Well, that's where all your police officers need to get
it's
together.
not us, it's our legislators. We don't have to say nothing. We can suggest.
Well, that's when you go to the,
But it's chief of police commission, they have suggested, you know, but it's not us, it's our legislators. They don't want to do it.
here's your legislature.
Here we go.
Here is, you've got, what's his name? He's the one who got our damn fire truck.
So,
And you got Frank Lucas.
yeah.
So what are you gonna do when that happens to your fucking daughter? Somebody beats the shit out
It
of
will
her.
be enacted because it happened to somebody important.
Well, I
That
know
happened
it.
to somebody important, nothing.
That's
When
what
I mean, let you drive, no matter how you drive.
And I think what happened, why when Brian Kelly came to this show, he got crazy at why. Wound him up, he said, newspaper, he said, I have to deal with her, like, I had her, and I had a shot at work for 6 months. And, we'd seen her, probably 3 months before his time. Well, she tells him that I, you know, and she I had which was she said, you know, and so he tried to answer her questions and shit like that. But, you know, she gets where she send me an email. It's like the first like, hey, buddy, we have this, and it's like, you're an asshole, or something like that. So I, you know, I'm not doing this. And by the end of the day, buddy, you know, I'm sorry, but you know, she was talking about it. And I'm like, listen, you gotta chill out. I'm busy. I'll get to you. So she twisted like a lot of situations. Like, one day she did work for me. She's back in the ambulance in the barn. I was like, whoa, I can out back in Australia. You know, it's like, you know, I got much back in the water. Yeah, not that I really give a shit. She said I shoot her out. And so, but anyway, her and this other. And it's hard to like with anybody.
Don't know.
And she, you know, she said, oh, that's right. So, well, they ended up fighting, even with like, you know, first of all, I don't like Sarah Lynn, and I really don't like Sean. So I'm definitely not gonna say anything to Sarah Lynn, you know, so I think she would, well, Sarah drops it, so then she has this head is big stuff, so winding up for 6 hours, and then he showed up to my work.
What is this at?
Cheyenne,
Who the fuck are these people? Kelly,
yeah.
Kelly Thompson ain't no fucking different than anybody else. All you gotta do is beat the fuck out of him. I'm trying to think of who Kelly Thompson is. See, I've got problems over with my ex-wife.
That's why we carry tasers.
He gay or not?
Well, I carry a gun with me all the time. I'll give a fuck who you're gonna start something with me. My life's in danger. Yeah, I'll put a bullet in his fucking head.
Well,
Because my ex-wife lives on top of the hill for both schools.
yeah.
And there's these fucking retard druggies who their house burned down downtown. Of course, it was drugs that probably was started it. So what they do, they moved them in up there. So she's had to deal with them. I came over one night. I don't even know who this guy is. I told him, I said, anybody, and there was all these young guys were sitting over one drug, they jacked up, one under up, fixing bread. And I said, I don't know who the fuck y'all are. Anybody going this way, you'll be calling during April, come over my ass, because I ain't gonna put up with this crap. The lady that runs the apartments, don't live there, she said, she lives in the woods. She probably lives in a house somewhere, she ain't got to deal with it. Well, Christie, she gets all these fucking complaints turned in about her, and it's these little motherfuckers go there, and so I just went up there one day, and every one of them sat outside there and I said, you fuck with this lady, you fuck with me, I live 3 blocks away from you, you wanna come visit, you wanna? I don't give a fuck. I don't like my ex-wife as a wife or anything like that, but she's still the mother of my kids, and grandmother of my granddaughter, and I fucking work with her. So I'll get you.
I stopped there in 2 weeks ago.
I need to find out who this guy is. I'd like to find out who he is. He ain't from Cheyenne.
Now, at least I always use it on my, I would have got it.
So these are the girls. So is this the run the ambulance over there? Is that, is it to run the ambulance over the girls that come in over there? Who's the two girls? One ball.
What are you on, Robert?
Fucking me, but I said Smith, I said,
Yeah. I don't even know any of very anymore. I go in the hospital, and I think the only one I know is Roy Kirk's wife. Yeah. I don't know any of them anymore down there. Yeah, that's been away from Cheyenne.
You guys done with this shit?
I got 2 letters. Thunder with Ford.
What was it? West on right tourniquet.
Yeah.
Ain't that right?
That's a fill in the blank question there.
You can't do that.
All right. We are on.
Excuse me?
Patient assessment and vital signs.
Oh, there was one thing I was going to ask.
You ever had to deal with that on Sheriff Fentanyl?
Do it?
Sheriff Fentanyl? Have you ever had to deal with anybody on that?
Uh-uh.
It's worse than morphine, and it's the new up and coming deal.
Have I ever had
Drug.
have I ever had to deal with anybody
These guys become very super violent.
on fentanyl?
It's carafentanyl.
Oh, Tara. Okay.
Cara, CARREA.
No, I give fentanyl.
It's a synthetic type of drug.
I got you.
Rob, did you get my mom's messages?
Oh, let me look here. No.
Well, the new student, she goes by Noni. She will be here at 8:30 tonight if we're still here, and she's going to take her test tonight, but she needs the link for the
Okay,
test.
yeah. I tried to send her an email today to see if I have her email because your mom had sent me that information, and I guess I just never put it in. And so she hasn't gotten any email. So I tried to email her today to make sure that it was the right email because it looked weird. And I haven't got back to her. So I'll send that link out to her again.
Okay, I'll tell her. I'm going to wait up here for her if we're
Okay.
not here.
That will work. I think we'll probably be here till then. Good chance of it anyway. So unless you guys just seat her. Thought you were leaving at 7.
Yeah.
You want to get that done before he has to go.
The game's gonna be over by the time you get done with it.
You ain't gonna like the result you're fixing to see. Yeah, it's bad.
It's at least a 90,
I hear about
It's at least a what?
a 95.
No.
75.
Like I said, you're gonna like the result you're fixing to see.
Well, I can give you recommendations.
No, I can't do. Go read the damn book better.
Watch your videos and I know that you're busy this week, but
So what it is, it's called a super busy weekend.
yeah, no, that's what I was gonna say. I know that he's busy, but
I actually had to force myself to sit down and take it when I did.
yeah.
Because we were taking the time I got up Friday till yesterday, we were just go all weekend.
Yeah.
So Robert, I'll definitely recommend you to go back and look up the ones you missed and stuff. And
Yeah, I was looking at them. I already started looking at one of them. This sounds like, oh my God, I can put it quick there.
then just make sure you read your
It was
chapters
just dumbass mistake.
for the next ones. So, objectives for this chapter can be referenced on page 262. So, once again, I'm not going to read them. We're looking at patient assessment, history, and vital signs. So, you guys can see my PowerPoint slides, right? Over there at Leedy.
Yeah.
Cool.
We can see them.
Yeah, I hope you guys can see them. Well, the last time I did this, I forgot to share my screen, and I did a whole video, and the whole video was of Leedy's ceiling while I was talking. So, topics are yes.
If you did decide to go to Leedy to do a class or something, we do have it set up here where we can put it up there on the TV.
Okay, I was just gonna leave this computer and this.
He's got it set up back here on this computer.
Okay, do you guys have a webcam? And
I
stuff?
do have one in my office that we can hook up to.
Okay, good deal. Because I might go up there next week and teach from there next week, and that way.
Yeah, if you want to, we've got the webcam in there. All I gotta do is keep it subscribed to you.
I actually like coming here because I'm only 12 minutes from my house.
Yeah.
When I'm at Leedy, it's 45 minutes. But if the weather's nice, I ride the motorcycle and I get a nice little ride in and stuff. But
Well, they said the next 9 to 10 days are gonna be just like today.
it was a little nipply out this morning
Yeah.
on that ride. So, all right. So, back. Back, I say. Oh, man. All right. There we go. So, the vital signs and history happens after the completion of the primary assessment. There it is.
You hear yourself.
Gotta refix my screen there.
Now I gotta go. I could, just a second, I could go in. I could actually turn you down. from here. So control room. We'll mute you, Mr. Aaron's. I think. Did you mute it, Robert?
I didn't hear
Okay, good deal.
No.
Well, I could mute it from here. I see you, and so I mute it. But I don't know what's going on with my little spinner thing there. All right. So you guys have two that you can look at now. So reason for the call, history, vital signs, and physical examination. Kind of lost my train of thought there. So the call. On a cold winter evening, you are called to a middle-class neighborhood for a woman complaining of difficulty breathing. Your EMR team has been to this address before and knows the patient often has serious bouts of respiratory problems. Before you arrive, the dispatcher updates you that the patient is not doing well. So what else do you want to know? If your team has been to this address before, what other information may be available? So yeah, so obviously always we're going to do gloves on, scene, safe, right? Awesome. Some other things that you want to know, or I guess the information that may be available to you is what is their medical history. And I'll just tell you guys that, and you guys might already know from working on the fire department and doing a little first response anyway, that you get to know different patients, and you get to know your COPD patients. They're notorious for at certain times of the year. And typically whenever it becomes cold, all of a sudden they have trouble breathing. Okay, because the weather changes, the air changes and stuff like that. And so you'll typically know these patients. So some other information that may be available to you just by talking to your crew is, hey, does anybody run her? Oh, you have what? What you guys? Oh, she has emphysema. Awesome. So you start to get kind of a little history beforehand, right? So patient history.
Did you guys at EMS run into the lonely people?
Yes, we do. The lone.
We have people, especially during Thanksgiving and Christmas time. There's people here in town that'll call the police.
Yeah.
And normally it's just a prowler call. I heard something out back. Well, as soon as we know who it is that called it in, we know we're going to be there for a while, because all they want really
Is a
is
talk.
somebody to come over and talk to them.
Yep. A lot of times EMS knows these people by the fact that we'll show up and their suitcase will be packed, and they're ready to go. Yep. So yeah, we do get the lonely people. Guys, on the ambulance side, if you guys ever start working on the ambulance, the best thing that you could do for these people is just take them to the hospital and just talk to them. Hey, how's things been going? Sometimes, especially because they're the ones that are 80, 90 years old that still have their faculties, sometimes they have really cool stories, So sometimes it's just kind of fun to listen to their stories. So chief complaint, why were you called? Symptoms, signs, clues, nature of illness, mechanism of injury. I thought we already went over chief complaint.
Yeah, but it's in this chapter too. This one says the main problem.
The main problem the patient is experiencing, why the patient called you today, is a chief complaint. So
That's what I was told you. That's why he on the test.
I know, right? So, okay. So guys, this is something that you are going to want to commit to memory. Sample an OPQRST history. I'm not sure if we're gonna go over. Let's see if we go over to OPQRST.
Sample history.
So sample history, signs, symptoms, allergies, medications, past medical history, last oral intake, events leading up to situation. It's been around forever, and it's a great tool. I've actually am trying to get my people to start before really anything else, because I'm just going to be honest with you guys. Rural Oklahoma, we're terrible at getting a good history on people. Why? Because we don't run enough calls to really be good at it. We have a tool though that works awesome to help us get an awesome history on a patient, and it's a sample history. And then you're gonna, I think we'll go into OPQRST history.
Yeah.
But your sample is your signs and symptoms. Okay, that's great. What's going on today? Well, my leg hurts and I stubbed my toe. Okay, signs and symptoms. And then you look and they have a bruise. That's a sign, right? Something you could see. Symptom is something they complain of. Do you have any allergies? Well, I'm allergic to you. Great. And why'd you call me? The medications. I'm on sulfa drug, or I'm allergic to sulfa drug, and I'm on morphine. A big bag.
1 gallon bags.
Yep. Yeah. Yep. You are correct. If you, and for law enforcement, if you do come across that person that has that big bag that you guys seem to be, encourage them. Say, hey, maybe you should get a list of your medications.
We do. We try to tell them, hey, write them down on a sheet of paper.
Yeah. So.
We got into a big argument with the family here not too long about an individual that passed away. Well, they had large quantity. They had a pharmacy in their house.
Yeah.
And we took all the narcotics and everything.
And the family is pissed about it.
They were pissed.
Yep.
They wanted them back. Basically told them, if you can bring them back from the dead and sign a bill saying that you're in charge of their medications, I'll be more than happy to give them back to you.
Yeah, you know why they wanted those.
No, yeah. They didn't like that response either.
Yeah. So last oral intake. So past medical history. Guys, I'm going to throw a word in there that they don't have in there. Past pertinent medical history. Okay. I don't really care that you had a knee surgery 36 years ago. It's really not pertinent to the fact that you're having a heart attack or chest pain right now. Okay. And so some ways of asking that is, have you ever had anything like this before? Yeah, I had and then do you have any other medical issues such as diabetes, hypertension, or anything like that? And they'll go, some people will go ahead and write down the surgical history, but you might cut them off. They start talking about surgery. Say, I really don't, for EMS purposes, for whatever, I don't really even know your surgical history. Be nice about it. Sometimes it's just easier to just let them talk. So last oral intake. Any idea why this might be important?
Yeah, what was the last medicine you took? Because that, you could have took something that one you weren't supposed to take with it.
There's some other things to that too. So let's say that you're having this intense pain right in here. Oh man, it's right. Is that cardiac or is it epigastric? Well, what's your last oral intake? Oh man, I ate 46 tacos 30 minutes ago from Taco Bell. And so now maybe I'm not going to tell you not to be concerned about the patient, but I will tell you that you can start to kind of see the picture develop here, okay? Their only pain is there. Have you ever had this kind of pain before? Yeah, last time whenever I won this eating contest last time and I had 38 tacos, man, same thing. All right. From eating tacos. Another thing is you can, if you do think they're may have to go into surgery right away, an emergency surgery, last oral intake. Well, they had all they had was their breakfast this morning, and that was at 8 a.m. and that was it. So there are some reasons why you want last oral intake. It helps you kind of determine what's going on. but also it could help other things, such as you would, kind of pinning down, the patients with diabetes and stuff like that. So, events leading up to the situation. Why is that important? Well, you really need to know why there. So you have the guy, like I told you earlier, sitting in the recliner, sweating like he was mowing the lawn, right, or working out. So what were you doing before this started? I was just sitting here watching Wheel of Fortune, and you just broke out in the sweat. Yeah, I don't even know why. House is a nice, cool temperature. They broke out in the sweat. They're having chest pain, and they're sweating, like they've been working out. It's time to kick it into high gear, right? So they complain of chest pain. You get there. What happened before this started? And they're sweating. Well, I was helping the police department fight with a patient in the jail. Okay. I actually had that. That's why I said that. I had a guy that he's complaining of chest pain, and this is one of those live and learn type calls. But in Wichita, we worked. We had a paramedical lieutenant. Lieutenants are in charge of the truck. So basically, with the lieutenant, as whatever they say goes. So we go to the jail, and they help to the fight, and we're running this guy for chest pain. The guy was healthy, he was fit, but he's complaining of this chest pain. And so whenever I palpate where the pain was, he winced. Whenever he moved his left arm, it increased the pain. So here I'm going off of, this is muscular, obviously muscular. And so we're getting back to the truck, and my partner's like, my lieutenant is like, what are you going to do? I said, nothing really. I said, maybe consider some morphine for the pain, but I said, I think he strained a muscle. And she's like, you're going to run a 12 lead, and this is cardiac, and on and on and on. So I ran a 12 lead EKG. I didn't see anything, but she did. And she makes me call in for orders for morphine and all that for this guy for cardiac chest pain. So as I show up to the hospital, and the doc walks in, and he's all prepared, and understanding this is a time when EMS is trying to establish ourselves that we could read 12 leads so that we could get our patients straight to cath labs. Doc walks in, looks at it, throws the 12 lead back down on the patient, turns around and walks off. Why? Because the guy wasn't having a heart attack. The guy had a muscular pain. So I should have, as a competent ENT, said, you know what? And I was pretty new to Sedgwick County at the time, though, and so I didn't want to make waves. But I should have said, you know what? If you think it's cardiac chest pain and you feel strongly about it, then maybe you should run it, and I'll drive, because it made me look like I didn't know what I was talking about. So anyway, just a little story of where that.
Lieutenant didn't take the blame for that, did they?
What's that?
They didn't come back and say, "Look, I was wrong," did they?
No, she did not.
She let you take it off. Huh?
Yes, she did. And I felt like a fool. Not that has anything to do with your sample history, just explaining where the chest pain guy came from. So I'll try to reduce my storytelling tonight, but anyway. So it's important to get events leading up to the situation, because it can give you a picture of what's going on. Is he having chest pain because he just helped with the fight, or is he having chest pain because he's having a cardiac event? Or is he having chest pain because he ate 46 tacos, right? So it's never.
Hard shell. Probably hard shell.
Yeah, hard shell goes down sideways and gives you pain. So.
I just tell them I'm come up with
Hey, how many people since you've been in the EMS that you take to the hospital for heart attack, and they get there and it's gas?
I would say a lot less. I would actually say, I'd say a lot less since 12 leads become a standard of care that's happened. But I would say more than likely, I take them in thinking, possible gas, but I'll treat them as cardiac, and it does turn out to be a heart attack. With 12 leads, we can't always see the heart attack. Sometimes it's lab work. It's a non-STEMI, non-ST elevation myocardial infarction. But yeah, I couldn't even tell you. I couldn't tell you how many patients I thought it was one thing and just be completely blown away that it was something else. Like, wow, never called that. But so that leads me to a point, and I believe it was kind of in some of the last chapters, that I wanted to talk to you guys about. Do you guys always need to diagnose or figure out what's going on with the patient? No, right? Guys, we're out here in the field. We don't have lab. We don't have x-ray. We're treating signs and symptoms, right? If it walks like a duck and quacks like a duck, it's probably a duck. But sometimes it's a freaking goose, and so it's a baby goose. So understand that. You don't need to always figure out what's going on with them. It doesn't make you a bad EMR. It doesn't make you a bad EMT. It makes you a person. We can't always figure it out. Hell, sometimes people go to the ER, they get all kinds of lab work done, and they can't figure it out. So it's just what it is. So we treat signs and symptoms, and we kind of try to, and you guys aren't treating a whole lot. You're just trying to develop a picture for the incoming unit. And we just do the best we can. We try to err in the favor of the patient. So the response: patient is sitting up in respiratory distress. What the call was? Oh yes, the old lady, and it's cold. In distress, she's awake but cannot speak. Her lips are blue. Patient's daughter tells you the patient was sick all day yesterday. Patient complained of being tired and nauseated. Whoa, that's no good, is it? So guys, I don't know what they want me to ask you here, but what are some things that really concern you about this patient?
Bluish lips.
Yeah, the bluish lips.
Sick for 2 days and trouble breathing.
What is a really bad one there?
That she was sick all day yesterday.
On her way.
And she's
nauseated.
She can't speak.
Yeah.
She's so her airway is she's in a condition now where she can't even get a big enough breath of air to say a word, right? And her lips are blue. She's cyanotic around the lips. She has a major airway issue, correct? Okay, so I'm not going to tell you to jump straight to the bag valve mask, but this is one that you might want to consider assisting ventilations with a bag valve mask. She's hypoxic. We'll definitely want supplemental oxygen administered to her, correct? But without knowing her respiratory rate and depth, I'm not going to tell you to go straight to the bag valve mask. I will have to look. I'm not sure if you guys could assist with a breathing treatment, but if you can, this would be a patient that you would probably want to try to assist her with a breathing treatment. She may be too far gone for you guys to be able to get one down. And so what we'll do as EMS is I'll do an inline breathing treatment. So tonight she became short of breath and it got worse fast. Patient has a history of pulmonary edema. Oh no, that's not good. Your partner begins assisting ventilations. Yay, you assisted ventilations. So what do you guys think? Appropriate treatment? Assisting the ventilations?
Yeah.
Yeah, definitely. I will tell you that this patient can be fixed. There's a good chance, I'm not going to say 100%, there's a really good chance this patient could be fixed by even a basic EMT in about 45 seconds with the right equipment. At one time, this history of pulmonary edema, you're going to hear wet breath sounds if you hear any in this patient. But some things you're going to see is you're going to see swelling. They call it pitting edema in the legs. Probably a little edema in the abdomen. And this history of pulmonary edema. If EMS shows up and they put a CPAP on her, there's a good chance before they even load her up in the ambulance, she'll be talking in complete sentences. Okay. At one time, EMS used to treat pulmonary edema in the hospital world too. We used to do Lasix, nitromorphine, to go ahead and open them up and pull the fluids out. Problem is, a lot of these patients are already dehydrated. Just because they have this fluid on them, the fluid's not where it should be, and so they're dehydrated. So we go pull all this fluid out of them, we just make them worse. So we have found, or through research they found, that if you go ahead and start an IV on this patient when you're doing these things, that helps them. But then the standard of care kind of shifted, and now it's going to a CPAP. CPAP is a continuous positive airway pressure. So basically, as they take a breath in, they have some pressure. As they breathe out, they're breathing out against pressure. That pressure keeps the alveoli open. I'm going to show you guys a video just because they have this on here that shows you what a lung looks like with PEEP. Understand, PEEP is a portion of CPAP. Okay, positive expiratory or end expiratory pressure means that you just have positive pressure as you're breathing out. I said CPAP, continuous positive airway pressure. So we have pressure both on the exhalation and inhalation. So understand that even though the video I'm going to show you is not 100% the same thing, PEEP is an element of CPAP. So I'm going to pull up a video here for you guys. I think it's really cool. I think it'll drive home the point of the importance of addressing it. Hopefully I don't stop our YouTube broadcast. Lady, send me a text if I do though, okay?
Okay.
You see what I watch a lot? Motorcycles and fighting and off-road stuff. Oh, and Justin Bieber.
I think it's Stone Cold. So do you think Conor McGregor really?
Do what?
You see that whole deal with Conor McGregor and Dana White and everything?
Oh, huh, what's going on?
Conor says he's not hurt. Dana says he is.
Oh, because he broke his foot.
Yeah.
So Dana's not going to let him fight
No.
in 205?
Yep. I thought he was out.
We are recording again. This is a different angle.
Okay, so this is a lung without PEEP, right?
And we're going to go to
So see how it collapses each time? Okay, now they're going to put PEEP on. Look at it recruiting all those alveoli.
Okay, complete recruitment. And back to zip.
Okay, turned off the PEEP. You see the advantage, huh?
As you can see, some of
Let's see what this video is. I don't know if I've seen this one.
After the surgery, I could not take the grin off my face.
Oh man, I bet.
I think I smiled there.
Und Piep 15 bitte.
Why are these done in foreign countries? Oh yeah, so they can do cool things.
Piep 20. Piep 20, ja.
I don't even know what the hell's going on here.
So, 25 bitte.
I don't see what's going on. Does anybody else?
Well, it said
It started up with 15, now they're at 25.
Ah, jetzt passiert was? Jetzt ja, so bleiben, so bleiben, so bleiben. Lass mal die 25 noch. Aber dann musst du dann schneiden. Ja, ja. Noch so bleiben, so bleiben, so bleiben. Genau. So, wir wollen mal weitermachen. Ja, Jakob. So bleiben.
Well, I think he'd be healed up before 205 though. I wonder why Dana's not letting him fight.
Okay, und
Because
jetzt
Connor's not
30
winning? Connor, I mean, people doubt him. He's a good fighter.
I think it's simple. Are you hurt? No. For your medical release, you can fight. And if someone fights and he is hurt and he ends up
Okay,
screwing
weiter.
his career, then it's on him. Yeah, it's on him. Don't hold him back.
All right, so
Did he sell his company for $3 billion?
no, that's Dana's he was just president. He just had a portion of the ownership. So I know it really wasn't exactly part of this, but you guys see the importance of PEEP now. Remember that whenever we get to airway stuff, okay? So vital signs. I drank so much water, I gotta get through these slides so I can go pee again. So that guy, one of the vital signs here is an intense staring contest. So make sure that you win your intense staring contest. No. Looks like he's checking a pulse. So, senses, sphygmometer, and pen light. So your senses, you're going to feel for a pulse, right? You're going to feel for equal expansion and excursion respirations. A sphygmomanometer, a blood pressure cuff. You're going to take you're going to take a blood pressure. And the pen light, you're going to check for pupils and the response of the pupils, right? So you guys probably check some pupils every once in a while, don't you?
Oh, yeah.
And so let's talk about pupils a little bit, because it's all kinds of fun. Whenever you see those guys that are all doped up on heroin, what do you usually see?
They're like the size of your freaking fin.
Yeah, they're constricted,
Yeah,
right?
constricted, yeah.
They're tiny pinpoint. Basically, the body's like, you know what? I'm just gonna chill here. I'm just gonna relax, and so that the pupils don't need all this light. What do you guys see with the meth people?
Theirs get real big.
Yeah, you can't even see the color of their eye.
Yeah.
Right. A lot of times, whenever you have that person that's on that stimulant, their pupils are huge. It's like, gosh, what color are your eyes? And you can't tell. And so understand that you might see both these in some sorts of injuries. That it could be a neurological thing, especially with a head bleed, you might see them. So the pen light's important. If you don't have a pen light, can you still check the pupils? Yeah, you just cover their eye so that it's dark, and then uncover their eye, and you can watch a pupil.
Should react.
Yeah, it should react. So it should go from big when it's in the dark to little in the light, because it's trying to adjust how much light it allows in for the person to see. So for your respirations, breaths per minute. So how many breaths are they taking in 1 minute? I don't typically, and we'll see. Okay, yeah, they do. And say I don't count for a full minute. Typically, what I do is I put them on CPAP and I'll let that count it. But count for 30 seconds, multiply by 2, right? So you get you'll typically get about 6 to 8 breaths in that 30 seconds. Multiply it by 2, 12 to, what did I say, 6 to 8, 12 to 16 breaths per minute. You're good to go. And then assess for rate, quality, and sounds. Guys, remember I told you with your breath sounds, you need to use your stethoscope. You need to listen to those breath sounds. Even if you know that patient is not complaining of difficulty breathing, you need to listen to breath sounds so that you have a good idea of what normal sounds like. It's a lot easier to tell abnormal whenever you know what normal sounds like. Now, there are going to be breath sounds out there. It's just obvious. You put stethoscope on there and you're like, and you're like, oh my gosh, there inhalation. There you have wheezes on inhalation and exhalation. That's obvious. But if you train your ear to listen to breath sounds, you start to hear the little things too. I told you guys to rub some hair by your ear, that pleural rub there. Whenever you hear wet breath sounds, you might hear just a very light crackle. Sometimes it's very hard to distinguish that crackle from the normal breath sound if you're not used to listening to breath sounds. So I'm going to just say it, listen to all breath sounds so you know what normal is.
Can I hear your lungs?
Yeah, that'll all be big breasts.
I don't know if you go over this in the book, but could you tell us what a good thing is to having a jump bag?
A good thing to having a jump bag, I'm going to tell you, I'll tell you this. If I were to do a first aid kit, my idea of what a first aid kit has changed drastically from whenever I started to now. I would have.
Everybody's got to look like
I didn't know this. I didn't know this.
Basically, I would have my stethoscope, and then you want to think about what are you wanting to treat out of the jump bag. So, Boy Scouts asked me the other day, some 4x4s, a triangle bandage or 2, and some tape. If you're getting serious with it, maybe a piece of Vaseline gauze. You might also want to take like something, scissors and something to clean that wound out. Some either little small bottle of sterile water or something. I think the simpler that you can make a jump kit or a first aid kit, the better off you're going to be. Now, let's say that you're going to make it for you. You might want to go ahead and consider putting a bag valve mask in there if you're going to carry it in your cruiser.
Yeah, I carry one in my car.
If you're going to carry some, that's huge.
And I know some people that carry really, really large first aid kits. I mean,
yeah, they do. You know, and the thing is, and have you ever seen anybody use anything out of that first aid kit?
the only time one of the deputies carries a very large
First aid kit.
And the only time I've ever seen anything used out of it was a gunshot victim where he shot himself and went through his head into his head.
Ow.
That's nasty.
That's the only time I've ever seen.
So she dead too?
No, they both lived.
Well, that's pretty. How did that happen?
Because whenever he shot her, he went like this, and so it just like skimmed him and skimmed her. Actually, we found a bullet like in the back of her head.
And so you got, I mean, basically took some 4x4s and put on there. So.
And we didn't even know she'd been shot, so she starts saying, "I got a headache. I got a headache." And we found it.
That's
after
crazy.
back in school with her.
So I don't know if you guys heard the story, but he said the only time I seen a first aid kit used was whenever a guy shot himself in the head, and the bullet went through his head and into his girlfriend's head. But the guy turned his head a little bit and got skimmed, and then it went into her head, but just didn't penetrate the skull and went around to the back of the.
Went actually in here under the skin and rotated around.
Yeah.
Here.
Oh, that hurt like hell. So they asked me about first aid kits, and guys, it's something that you need to really think about what you're going to use it for. Are you going to use it like you in a cruiser? You might have a glucometer. If you can get them for free. Glucometer, bag valve mask.
I've got glucose meters.
Okay.
We've got about 8 of them at the house.
Okay. And some very basic bandaging. I'm just gonna be honest with you. In however many years I've been in EMS, bandaging wise, there's very few times that a 4x4 just doesn't take care of it. Now, we've had some where we have a large trauma dressing, but I don't know. So, tourniquet would be awesome in your first aid. I would do the tourniquet. So, might try to get back with you guys and get you kind of a good EMR type first aid kit. Not one that's overloaded. I hate to you're just not going to use it.
Well, that's what we were talking, like an EMR trauma kit, What we might need on, just nursing stuff.
You will want to, and I believe it's going to be in your book, you will want to know what they're looking for in respiratory and pulse. So you'll want to know that quality. I'll just go back to it real quick so I'm not giving you guys. Oops. So respirations is breath per minute, chest rise and observe their chest rise fall. That's for rate, quality, and sound. Okay, you want to know that. So pulse, beats per minute, count for 30 seconds and multiply by 2. Some people get pretty creative and count for 10 seconds and multiply by 6. But understand that if they have something like AFib, atrial fibrillation, and you do that method, you're going to be way off. Okay, 30 seconds is going to give you a lot better estimation of what it is. So assess for rate, quality, and regularity. I would know these things that they're telling you to assess for, okay? So pulse, assesses the pulse, the radial artery. Everybody know where how to find the radial artery? On the thumb side, right? Right underneath, right in between the ligaments there and that radial bone. Got a little notch. So the carotid, we already talked about where it was in the thing. The brachial, we talked about it in the CPR section. And then femoral. And I'm going to tell you guys, femoral artery is a kind of a hard one to find. I I've never checked for a femoral artery. I lied. I have whenever we're coding a patient and we think we got him back. But just on a regular patient sitting there talking to him, I don't check the femoral artery. Radial, not radial, I'll go to carotid.
What about for, say, a car wreck that you spot on the road and you go down there and you don't feel one up here or a heartbeat and he's cold? Would he have?
No.
Would you look?
Nope.
Okay.
If I don't feel a carotid pulse and he's cold, if you have your stethoscope, listen, you don't hear any heart tones, he's dead. Or
He's thinking it's a problem.
it's yeah.
I've always heard about cold.
Now it depends on what kind of cold you're talking about. If he's a block of ice cold, please don't get retarded with this, or sorry if I don't mean to offend anybody with that term. Don't get silly with this. Don't take that. They're not dead until they're warm and dead to the extent that they're frozen solid. But we're not goldfish, right? So for frozen solid, like I'm serious, the body's frozen solid, and they're dead. They're dead. Okay. That term goes for somebody that falls in the friggin' ice water, and they are pulseless and admit from that situation. They're not frozen solid. If you have to get a hairdryer out to thaw them out, and I'm saying this because Roger Mills did this before I got there, and I just laugh at him every time. If you have to get a hairdryer out and thaw a patient out so you can do CPR, I promise they're dead. Okay, they're dead. We're not goldfish. You're not gonna bring us back. All right. Sorry, rant. Skin, color, temperature, condition, cap refill times, less than 2 seconds. And I'm ranting because whenever I told them, they're like, what? You got a hairdryer out to thaw them out? Why didn't you guys just call it? Well, they're not dead until they're warm and dead. Yeah, that's not really how that works. The thing is, I took him into the hospital, and the hospital's the one that got him the hairdryer. So the hospital participated in this event. So, color, temperature, condition, and if this is somebody's family member that was frozen solid, I'm sorry too. I gotta be more sensitive. So, capillary refill time less than 2 seconds is normal. Be careful with cap refill. Some people get ate up about this, and it's like, oh, it was greater than 2 seconds. Yeah, but they're also 96, and they're freezing cold. If they have cold hands, maybe they don't get real good circulation in their hands. Cap refill is not going to be a good thing to use. Color, temperature, and condition of the general skin is. I look at you guys in here. You guys all have good color condition, and temperature of skin. You guys are solid. Go stick your hand in a bucket of ice, and it takes cap refill 5 seconds to come back. You're still good to go. Your hands are just cold, okay? So once again, treat that patient. If they look normal, that whole looks like a duck, walks like a duck, quacks like a duck, probably a duck, probably are. Now, you get somebody and you're thinking they might be in hypovolemic shock or something like that. Cap refill's delayed. It is another clue to the puzzle, right? So blood pressure, systolic is the top number, diastolic is the bottom number. You get this with the blood pressure cuff. I have a mannequin that I will bring here on a lab night that you guys can take a blood pressure on. I'll teach you guys to take a good blood pressure. I'm able to listen at the same time, or actually I'm able to set the blood pressure, and then you have to tell me what it is, get pretty close to it for me to say, okay, you're good to go. I understand that some people have a hard time hearing through stethoscopes. That's cool. We'll work around it. I'll teach you some other things about blood pressure. But know that you can get a systolic by palpation, but you have to have a blood pressure cuff to get both systolic and diastolic. So systolic's the top number, so the 120. Diastolic is the bottom number, over 80. Let me see if they want us to say what each one is. Systolic pressure is the pressure of the contraction of the heart Diastolic is the pressure, the relaxation of the heart. So as the heart relaxes and everything slams shut, that's what you're hearing. So blood pressure, normal blood pressure for a child, guys, you'll need to know your normals, okay? So let me see what slide we're on. 21. I'm going to go ahead and go to the restroom real quick. I'm about to pee my pants. I drank too much water.
That was like 59.
I gave him one answer and one. I was like, that right there is not no responses. So I'm gonna leave that alone.
But you don't spend enough time in class, you know, so, man. Huh?
But he was supposed to do that before he took his test. Probably taking his test and not passing, probably
Motivated a little bit.
to drop it.
Well, you got all of us take it.
I tried to use my book. I did. I said, you can use my book. It's got all the answers, all the questions, you know, it's all the quizzes and stuff. I said,
That helps me out going a mile.
yeah, that's what I told him. I said, you can use my book. It's got all the questions to the reviews and everything already answered in it. Like, oh, yeah.
Talking about your friend?
And I'm not saying he wasn't busy this week. Race weekends are really bad weekend for him. He gets stuck doing a lot of shit that he shouldn't have to do.
That's too bad. I'll work with him now. So now we get on through a class and he continues on that. Yeah. Only so much a fellow can do to help a fellow out. So normal blood pressure child is 90 plus 2 times patient's age in years. For systolic and 50 minus 80 or 50 to 80 for diastolic. So kid is 10 years old. That's 90 plus 20 is 110 over 50 to 80. So adult equals 100 plus patient's age in years up to 150 millimeters of mercury. So let's see if mine's normal. I think I remember 128. I'm good to go. I have all the way up to like what 130, 138. So for systolic and 65 to 90 for diastolic. So I would know that. Did it just change again? No, that's weird. So how to auscultate a blood pressure. Apply an appropriate sized blood pressure cuff on the patient's arm. Guys, this is very important. A blood pressure cuff it's called an index line. And if you ever look at a blood pressure cuff, the index line will be a white line that goes from top to bottom of the blood pressure cuff, usually on one end. That index line, as it wraps around, has to go past the range, or the index line has to fit inside the range. If you go to wrap around their arm, they got this big old fat arm, and you get the Velcro to latch, but the index line is not in the range, that cuff is too small. You go up on sizes, okay? I'll show you in the lab, don't worry, but I just want you guys to understand that. It drives me insane whenever people freak out about a blood pressure, and then I go look at their cuff, and it's not even close to the right size of a blood pressure cuff. Something else on blood pressure, especially if you're using a automatic machine. If you get a blood pressure that doesn't seem right, it's probably not. You get a blood pressure that says 70 over 40 and the patient is conscious and talking to you, it's probably not right, okay? Especially if they're like not dizzy, not weak. They're like, no, I feel fine. You're like, no, but your automatic machine just gave you a bad reading. I highly recommend that, and actually the state says for EMS anyway, that you have to take your first blood pressure with a manual blood pressure cuff. So you don't get caught by that. Some people get all weirded out by it. So once again, goes back to treat that thing with hair, not the equipment, right? The equipment's just a tool. It's just there to help you out. But if it doesn't make sense, investigate. Kind of same thing if it says 280 over 140 and the patient doesn't have a headache, and it might just be weird. But chances are your blood pressure's wrong. So find the brachial artery and place the bell of your stethoscope over it. You'll also have on most blood pressure cuffs an arrow that says artery. Line that up with the brachial artery. Basically, kind of comes down right about right under the head of the bicep muscle. Okay, so that's where it's going to line up. We'll work on it whenever we get the mannequin and stuff over. Inflate the cuff and listen for sounds. As you inflate, you'll lose the sound. Once the sound is lost, inflate 30 millimeters more. I have a different way of doing it, but this is probably the way that you should know. I typically go to 160. If I don't have any sounds at 160, I'm not sharing my screen anymore, am I?
Wait, you said you did that.
No. Freaking meaty. Oh, wait, yeah, I am. Never mind.
I was always taught to jack it to 200.
Jack it up to 200. Jack it up to turn.
I promise you that I promise you, if you are jacking it up to 200, as you stated, you're causing them undue pain.
But you gotta remember,
That's salt battery right there.
you gotta remember though, when I took my CNA test, this was back in the 80s and 90s, so.
Well, this is true.
I mean, no, I mean,
Yeah.
but
And it was in
I've changed
Texas.
since then.
Yeah,
It was in Texas, right?
No,
So everything.
And I took a correspondence class from the Philippines, so
Yeah.
no. Yes, everything does change. Jacking it up to the 200s, you're causing them undue stress. But if that's what you know and you're okay with that, so be it. Like I said, I pump mine to 160. If I don't hear sounds, I'm good to go. If I do, I go to 180. Oh crap! Now I know I'm doing. Then it's code. Then I jack it up to 200 or 220. But have your way, but know this way, because this way is the way that you'll be tested on if there's test questions over it. But as you inflate, you'll lose the sound. Once the sound is lost, inflate 30 millimeters more. And then what you're going to do is see if they don't tell us. Once you get up there, wait, did I go backwards? Sorry, my bad. Deflate the cuff slowly and listen. When you hear 2 consecutive beats return, record the systolic pressure. Continue deflating, listening to the pulse. When you lose the sound of the pulse, record the diastolic pressure. I'm not sure if they're going to tell you in here or not, but continue to listen all the way down even though you've recorded the diastolic pressure. You can have an oscillatory gap. So you keep going down, all of a sudden the pulse there, you can hear it again. You had an oscillatory gap. Continue to listen, okay? Is there a party in there?
No.
TV, that's TV,
No, that's his son.
What's up?
Dalen?
We just had a visitor. So, blood pressure by palp. Palpating the blood pressure. Does anybody know what palpating the blood pressure even means?
Heard of it.
It's a crazy thing. You're feeling for a blood pressure, okay? Palpation, you're feeling, right?
Right.
So, all right. Apply an appropriate size cuff to the patient's arm, just like you would with the other one. Find the radial pulse and palpate it as you inflate the cuff. right? So now you have the radial pulse, you're inflating it. Once you lose the pulse, inflate the cuff 30 millimeters more. Deflate the cuff slowly, feeling for the pulse. When you feel the pulse return, record the systolic pressure. You cannot palpate a diastolic pressure, so the pressure is recorded as 120 over P. All right? You can, for the EMS peeps, you can record it like that in most all charting software. Do not record it as 120 over 0. Okay? All right. So there's a picture of the fellow palpating a blood pressure. Notice that he found the radial pulse. Gonna pump it up. All right, pulse oximetry. I'm going to get on another soapbox here. Normal is 95 to 100%. Sensors saturation of hemoglobin is what it picks up. CO poisoning will give you a false reading. The pulse ox, the book says, measures how much oxygen is in the blood. It said that. I actually read it, and that's wrong. The pulse ox measures bound hemoglobin. Okay, the hemoglobin is either bound to O2 or CO2, right? So it's measuring how much is bound to it. So it can be full of CO2 and still read between 95 and 100. Now, I told you guys before that these are all just tools. If you have a pulse ox reading of 60 and they're talking to you, it's wrong. It is wrong. Yes. Unless they're a heavy smoker and they have amazing mental capacity. Anyway, one way to tell if your pulse ox is at least reading accurately as bound hemoglobin is you see that 95 right there? That's that oxygen saturation. You see that 59? That's the heart rate. If you reach over there and you palpate a pulse, so you feel for a pulse, and you count the heart rate as 90, that O2 saturation is wrong, okay? But if you palpate the pulse at, let's say, 62, then that pulse ox is probably pretty darn accurate. And I say that because I've run calls. One of the most memorable was in Wichita because it was a rehab hospital, which I thought was insane, Wesley Rehab Hospital. And we get called to a difficulty breathing. So we go in there, we have all our gear ready to go, walk into the room, and the patient is sitting there in bed, warm, pink, and dry, not complaining anything. Actually, they were a little confused why we were standing in their room. And so when we asked, are you having trouble breathing? No. Okay. And we go to I believe it was an RN. So what's happening here? Were they having trouble breathing and they gotten better? No, my pulse ox said that their O2 sat was 70%. Okay, well, ours said 95%. And, there's a good chance that maybe yours wasn't reading correctly. Oh, it better been. It's brand new. Okay, so was your patient any different than this whenever you check their pulse oximetry? No. Okay. Well, I'm going to go talk to the doctor, Or do you really want us transported? You'll have to talk to the doctor. Okay, let me talk to your doctor. She calls him up. And hey, Dr. So-and-so, this is Rob with Sedgwick County EMS. We're here with a patient of yours. They're trying to send over to Wesley for difficulty breathing. The patient's not complaining of any difficulty breathing, and they think that it's low, or they need to go because of pulse ox 70%. Ours says 95. You want this patient to go by ambulance? No, I don't. I'll take care of it. So I don't know what happened with her and her job, but I bet she wasn't happy with me the next day. So anyway, no slide on nurses because I watch my EMT peeps do the same thing that drives me insane. Freak out over a pulse ox reading on a patient that just doesn't make sense. Check your patient. Treat your patient. All right. If it doesn't make sense, check your equipment. You do want to get your equipment running right, so you have a good thing. good numbers. Sometimes your equipment's just acting wonky that day. All right. So pupils, shine a pin light into the patient's pupil. Yeah, that's fun. Assess for reactivity, abnormal pupil findings, non-reactive and unequal compared to one another. Gosh, I got stories about pupils too. Had a guy stabbed in the eye. I was getting ready to transport for a head injury. He'd been stabbed in the eye previous, and he's just drunk at a ceiling. Man, and it's like, no, he's just drunk. Well, we did go ahead and transport him, but we stopped all the drugs that they were starting for the head injury. So, as your partner bags the patient, EMS arrives. Pulse is rapid, weak, and regular. Skin is cool and wet. Fingernails are blue. Blood pressure is 92/50. So, good job, EMRs. You saved her life by bagging her. Paramedics attach CPAP device to the patient to treat pulmonary edema. Paramedics transport patient to ED. So, yay, paramedics! You put her on CPAP. Not even kidding. I had a patient that I gave the option for me to intubate or do CPAP. She didn't really like the idea of being intubated, even though the hospital said that she would not accept CPAP. She was talking and giving thumbs up as we were walking out of the hospital. So, happens that fast. It really does.
The darkening of the skin, say a black person or something, did we go with it? No.
You'll want to look, so
Will they still have a tint to them?
they will, it's just harder to see. Okay. I would look more in the teeth, gums, lips area, beds of the fingernails, because they're still, if you ever look at a black person's hands, they're still
Right,
have,
they're lighter on the inside.
yeah, lighter on the inside, but they also still have pink underneath their fingernails.
Okay.
So those are good places to check. But yeah, that's a good question because.
It's in our stock.
Oh, what does it say?
It just says to assess the skin of a dark skinned patient, you should check the blood pressure, palm of the hands, forehead, or back of the neck. I thought palm of the hands.
Yeah, palm of the hands because you have a lighter one. But check in the book because I may have missed something in that question. So, all right. What is the following? Which of the following is considered a symptom?
A symptom to have chest pains.
Yeah. Hey, because that is a symptom, right? So which one is I guess they're all kind of signs, aren't they?
Yeah, they're all three other.
The S in sample history stands for signs and symptoms. Good job. A, allergies. All right. It is now 8:35. Is a new student there, Jacinda, to take her test?
Not yet.
Okay. See, this was chapter. What's chapter 12? There's a good pupils chart, guys, on page 277. I still highly recommend you guys read the book and do the chapter reviews. Obviously, I think you guys did awesome on the test. I think the chapter reviews helped. I'd say maybe not. I don't know. What's that?
It helped me study.
Yeah.
Me study too.
We could do secondary assessment. We'll go ahead and do chapter 12. I'd like to get done so that we could do some review. Maybe hit some review at the end of tomorrow night, and then definitely review on Wednesday. Same thing applies. You guys have problems that you're studying for the test. Obviously, shoot me a text. Sometimes, guys, I get back to you really late because I didn't, for whatever reason, your email gets buried So if I don't respond, you might send me another email. Now, for the guys that heard the story earlier, don't go psycho on me. But understand that sometimes for whatever reason it goes away, it gets buried. So
That'd be wrong.
so
I'm just like.
any questions at Leedy?
When do we have to have our next test taken by?
When do we have to what?
When do we have to have our next test done by?
I'm gonna try to have it kind of same thing. Try to have it done by Monday. But if you need an extension or something like that, I'm willing to work with you on it. So.
Well, when are you going to email it to us?
I will email it out Wednesday night. I have not even made it yet. Do you need it earlier?
If you could give it to me right now, I'll take it right now.
No, Jacinda.
Okay.
I have not even made it.
Are you still there?
You got that one?
All right. Can you guys hear me? Hear me now?
Yeah.
Okay. I have a bad battery. We didn't talk about anything. I have a bad battery on this computer, and I accidentally kicked the power switch, so it kicked me off. So
Hey, I have a question. What chapters is the next test over?
it will be all of section 3, which is 9 through 13.
Okay.
So I'd like to get through 12 tonight, which will make this kind of this will make try again. It will make tonight probably the latest night. So I'll get through this tonight and then do 13 tomorrow. Start review questions tomorrow. Give you guys a chance to kind of catch up, and then
Wednesday.
what's that?
What are you going to do Wednesday? First half.
Wednesday we'll just do more review, answer questions, and I'll send out. Jacinda, if I get the test done tomorrow, I'll just go ahead and email it out tomorrow for you.
Okay.
I'll try because it's not going to be as big as this last one. Even though we're still doing 4 chapters, I'll probably pick 7 questions for each chapter. Yeah, I'll try to make it about 50 questions. So it's about half of what this last one
So
was.
you ain't got no room to screw up, boys.
I'm gonna also try to figure out how to allow you guys to see and print the ones you missed.
You can see them.
Yeah, and I just turned that on. You couldn't see yours, could you? Oh, you could?
Because after I took it, you can see the ones.
Yeah, I saved it on my computer so I can go back over.
Okay.
I just don't have a printer.
I was talking to Danny about it a little bit, and I wasn't sure how to do it. I just need to take one, and so I could give you guys instructions on how to do it.
Yeah, take it first test.
Hey, point of being a super duper paramedic if you don't get the answer sheet, right? All right, let's go ahead and get through this last chapter. Hey, Jacinda, whenever that new girl gets there, or do you know her email address by any chance? Your mom sent it to me, but I'm worried that it's wrong because it just looks weird.
I don't know. My mom's here. I'll ask her.
Okay. Does anybody have a charger for a Android? Yes.
You don't have a cord?
Oh, I do. I'll go get it. I'm gonna go get it out of my motorcycle. My phone's about here.
What?
You have a warrant.
I think so long on this, and I looked over and
Alright.
just thought too much into it.
I just gotta hurry.
That's, well, like that, most of them, it was like, oh my God, answer was this, but then I said,
Rob, what email do you have?
he's back now.
What's that? Sorry.
What email do you have?
Here, let me plug my phone in. That way I can just go look at my Gmail real quick.
All right, I'm gonna start there.
Sent.
We're good.
Inmates swear.
No, fighting each other.
Let them fight. Let them fight. It's all in.
Every time this happens, Bacon County's like,
We don't have any deputies in the area.
Let them fight each
They don't
other.
have nobody lives in Sarah.
Oh, they do. They're not calling out.
You get charged for it?
I have WONENAKNIGHT@gmail.com.
That's right. That's what she said.
Okay, that's right. Cool. Okay, you know what? I'll just go ahead and send the link out to the test right now to her.
Okay.
And for future reference, if anybody needs it or whatever, you could send them the link. You could send them the link because you have to sign in to take it. So the link is it'll get it to them and they'll sign in.
Okay. How do you do the YouTube videos? You just go to YouTube and what do you have to look up?
Does she need the YouTube videos?
Well, I'm just reading my mom's text messages to her and she says she hasn't received any information to watch them. So I didn't know, like, I haven't watched them either.
Yeah, I've sent out a link. I'll send out one right now and I'll add her to the thing so she starts getting everything.
Okay.
I need to. Sorry, guys. I'm doing a little housekeeping before we move on.
Darren says he hasn't taken his test because he's been doing interviews and investigations for 2 days.
Yeah. I think Darren is a slacker.
Well, duh.
What did you say she goes by?
Noni.
How do you spell that? Oh,
I don't know.
Noni. N-O-N-I.
Noni. She's passing the iodine plant right now, Mom. She just sent you a text message. She'll be here in like 3 minutes.
They're gonna hire her. I haven't heard. Problem is,
Nobody wants that job in Chicago.
okay.
The only way I take that job in Chicago is if they gave me.
So now she's been added. So now I'll send out.
The only way it's gonna,
Uh,
they're gonna have to get rid of the drugs.
And then they go
And
in
then
there.
they'll see us trying to build that fucking wall. And I was
I'll
out,
place the first brick for him, he'll do it.
I tell you what, there's there's a group from, down south somewhere. They're all union workers, and they said, if Trump gets president and he starts building that wall, they're gonna be the first 200 guys in this good work.
The wall's not gonna do any good, they got shovels, I know they're using.
Well, no, I've heard.
Have you seen that show on TV where they show the tunnels on the ground? I think they got one they're showing.
let's see if I can find the link for it.
Just a manhole cover, they slide it off, do it.
That's it when you go by there and drop sign, I guess.
I will. Hey, Jacinda, I will send out one as soon as this class is over, because it'll.
Okay.
That works. So. All right. So. What I mean, I know that I should have done this. Let's take a quick 5-minute break, and then we'll get started on the last one for tonight.
Okay.
To keep it Guatemala.
With all guards in, yeah.
Now, there is spots that they can't build a fence. They'll have to do something else. But
Think about it, a lot of them are hard workers.
So if you wanna come home,
They
you
get
wanna
free
go that
health
way.
care. And that's what's killing them. Us is all the free health care, all the welfare they're on.
this is usually,
Let's get a butter.
there's more, what is it, Somalians and Syrians and all them are bringing over now. Before they even get over here, they're already on insurance or food stamps.
Well, that's why he's gonna stop the refugee program.
Because you got them people.
You heard last week, Texas pulled out of the refugee program, didn't
Well, I
they? They
could
said
say,
no more.
Right now, have you ever heard of the Declaration of States?
Texas don't fuck with you.
Right now, there's 9 states. You're supposed to be
You're talking about, you know, Amarillo has the largest population of illegal Mexicans.
No, I said Texas. I don't consider Amarillo Texas.
Amarillo is Texas. Amarillo has the largest
You know what's in
concentration,
Texas?
not of Mexicans, I'm sorry,
Somalians.
of Middle Easterns.
There's Somalians. And then
Well, I mean,
there's
as far as the laws go here, if you don't fuck around in Dallas, Waxahachie.
Oh, yeah, Texas has some very strict laws.
They're your ass, especially Ellis County.
But the problem is, with the president we've got,
Get out
the border patrols, have you heard what happened to the border patrols? They cannot legally arrest them and deport them. Their hands have been tied down there for like 6
Well,
months.
that's why we caught a van going down the interstate out here. Pull it over, like, what are you hauling back there? We heard something moving. And they're like, we're just hauling furniture. So after permission, they get the permission. We open it up and there's about 20 of them sitting there pouring down sweat. I mean, it's hot as shit. We start getting them out lining up on the side of the road. We call Scott. We're supposed to call the sheriff. We call Scott and be like, got all these illegals out here. I don't have room in my jail. Put it back on there and tell me, get the hell out of here. So we did load them up, get out of here.
Let them go and see.
Because
what
if
we
we
got.
call ICE, then he has to hold them at the jail down here till they come down and get them. Till they come down and get them. I still think the funnest one when they had that accident on I-40 on River Bridge. We pull up in our patrol cars and all these doors pop open on this van. And all of some bitches go jumping off the bridge, one after another. I looked at Ronnie and I was like, somebody's got broken legs. We go running over there, they're all running down the river. About
about 15 of the subdivisions.
How far did they jump?
You ever gone over the River Bridge? What is that? Shit, that's a 30-foot? No, it's further than 30 foot. How far would you say that is off the River Bridge down to the river? The big bridge on the interstate.
Probably 50 foot.
Yeah, it's at least 50 foot.
They're jumping off of it?
Bunch of illegals.
Not even hesitate?
No, they just ran to the side and just jumped. The one here? Yeah. And it was cold that night. There was ice on the bridge. It was freezing.
What happens, they hit and just slid.
I told Ronnie, I was like, we're gonna find a bunch of frozen Mexicans tomorrow.
No?
And we started yelling out to them, hey, if y'all come back, we'll give you a warm place to go. Running. Get going.
Frozen burritos.
That's that night we had what, 4 cars pile up out there. But it wasn't. I don't think fire even came out there, I'm not sure.
Where the fender benders.
Most of them just sliding into each other, wasn't really any major injuries.
It's been 5 minutes. Everybody back? Back enough?
Tell them they need to pull their damn screen in, so we see some faces in there.
Why'd they put it at the, can we do that, put it at the ceiling?
No,
Why can they?
because they don't listen to me. Don't worry. Whenever I go there, I'll fix it. You get to see them. I'll put up 2 cameras. I'll put up one showing them so you guys can see them, and then I'll.
Yeah, put one in the corner where they don't see it.
All right.
So they could actually like sneak out of class and be out there
Yeah, they did that one night.
playing volleyball and stuff, and you wouldn't even know it.
I think he.
They don't sneak. They just tell me. They're like, we're leaving. Yeah, I think that's probably what they do. They don't listen to me.
not here. Hurry, yeah, you have to test now. I'll tell you right now.
They done got that sticker on.
Well,
just read
she's a LPN, Jacinda. And just current. She just did the LPN class.
This is good for me. I'm too old for EMT.
Heck, maybe they did leave.
So we should do 12 and 13 tomorrow.
No, we're gonna review more. That keeps us together. Oh, reason I said it. Yeah, Wednesdays. I have to go to Hutchins tomorrow night and buy donuts for everyone.
It's donuts. Just because I'm a cop, you think I eat donuts? Pizza.
What was it? The deal over at Elk City? The scene size up? No. That poker run last week or weekend before last?
Oh, man.
They were sitting there and they said, after we get back, you don't have hot dogs and all that, and then the donut truck's supposed to show up. Yeah, they had 4 of the Thunder Girls up there. I done left. I seen it rain coming and I got caught in it right after my bourbon. Turd floating quick.
All right.
They're gone, ain't they?
Lady, are you around?
Yeah.
Okay. You guys haven't been answering any of my questions.
I was talking on the phone. I wasn't listening.
Get off that phone.
Yeah. That's what they do the whole day is they don't listen to me. Ever. Even
That's
when
what I have the mute button for.
even when I go hang out with you guys don't listen to me. So, all right.
My mom says it's because you're boring.
Do what?
My mom said it's because you're boring.
Yeah. Yeah.
Chapter 12 is a big chapter, right?
It is.
20 pages.
Won't be very many slides. All right, so we'll get started.
We thought you was going here like the other night, and you said, yeah, let's keep going.
I am, except for my swimming, so we're going.
You should have ate a burrito before we got started.
I'd be sitting in there on the dang toilet going, what did y'all say?
Don't get me over going. I think
So-
I'm having a heart attack.
All right.
I'm gonna draw this computer in there watching the clip.
The topics: general principles of assessment, Medical versus trauma assessment, vital signs, and reassessment. So kind of going over it. So secondary assessment, systematic examination, anything else that may be wrong. So we've already gone through and we've already addressed our ABCs and any life-threatening injuries, correct? So now we're going to go back and we're going to do this systematic examination. So for a trauma patient, we're going to do a head-to-toe assessment. Hey, there's somebody.
What happened to that screen?
I don't know. Hey, it's somebody from Leedy. Yay. Hi. They're running.
That's the new student.
Oh, okay. Hi, new student.
My mom said that you need to be nice.
I didn't know people off.
I need to be nice to who? I'm nice to everybody.
Okay.
People vote on it?
It's not a democracy. It's freaking class. So, all right. So the systematic examination. So for trauma, you're going to do your head-to-toe assessment. And for your medical, you're going to do a detailed physical exam. So let's say they're doing chest pain, you're going to gear your assessment towards that chest pain. So dispatch. Oh, the call. Your response unit is dispatched to a patient who is not feeling well. As you respond to the scene, you wonder more about the patient and the variety of conditions that could cause a patient to not feel well. Guys, this is like a very common call for EMS. So even though the complaint is vague, what will be your first priority on the scene? Think about your primary survey, right? Your primary assessment. Still the same. Still going in. You're still determining that the scene is safe, gloves on. You want to go ahead and determine if you need any additional resources. You want to determine whether your airway, breathing, circulation is intact. Make sure that you don't have any life-threatening injuries or some other ones. Whenever we get the sheets, it'll make more sense. And then, so once that's all good and dandy, you're going to start going down and obviously talk to your patient. So observation, auscultation, and palpation, and the distracting injuries. Remember, I used the example earlier, the dizziness caused them to fall and break their ankle. Now they have an open ankle fracture. That's a distracting injury. Your true problem is from the dizziness. The broken ankle is going to be kind of secondary to that. So I've never heard of or used DOTS before. Deformity, open injuries, tenderness, and swelling. That's cool and all, but I don't understand its point. Let me see here. I don't know why they're throwing that in there. So whenever you read, if they come up with some really great reason why you should be using DOTS, let me know, okay? So I can start using DOTS. I want to be the cool kid. So assessing different patients. 4 types of patients: seriously ill or injured, non-seriously ill or injured, medical or trauma. So patient condition affects priority of secondary assessment. Serious versus non-serious. And then you're looking at your hidden conditions. Let me see if where we're at here. Indications a serious hidden condition exists include, but are not limited to, the following: a significant mechanism of injury, altered mental status, pale, cooled, sweaty skin, chest pain or discomfort, difficulty breathing, severe pain anywhere, elevated pulse, and respiratory rates. We already talked about these in the last chapter, right? So we're kind of just hitting on, just rehashing. So on page 290, you have integrating the history and physical examination medical patient, integrating history and physical examination of the trauma patient. In there, it looks like a pretty good graph. Ooh, hey, look, they go into the trauma patient and they talk about dots. So they visually inspect each extremity for deformity and open wounds, palpate each extremity for further examination for deformity, open wounds, and pain on palpation. So, whatever.
That seems more like something that a paramedic or a doctor would do.
Negative, Ghost Rider. So, let me see here. So, we're still in this case study here. You respond and observe the scene that does not appear to pose any dangers. There is one patient who is seated in a chair. He looks like he is having a significant difficulty breathing and is pale and sweaty. Based on this information, do you think the patient is stable or unstable?
I'd say unstable.
Unstable. Why are you going to say unstable? I mean, you're right, but why?
Because he is pale and sweaty.
Pale and sweaty. So it's a good observation. And what, I'm not even going to go there. Good job. Pale and sweaty. Look at the skin. You see that it's pale in color and sweaty. We know that things aren't working. Blood's not getting to where it needs to be, right? So this is not normal. One of your very first signs there. So medical versus trauma assessment. Continue. It is imperative to have a sweet mustache. That guy's mustache is awesome. I wish I could grow a mustache like that. I look like a 80s porn star when I try to grow a mustache. Slightly creepy. So, child molester. I don't look quite that bad. So, medical assessment, internal problems. We're going to talk about the sample and OPQRST history. Hopefully, go over and we will. So, what is sample history without seeing it there? What's sample history? Start with S. What's S?
Symptoms and signs.
Okay. What's A?
Allergies.
Okay. N. Okay. P. Okay. L. Okay. E. All right. Good job, guys. So now they have the OPQRST history. Let's see if they're going to start us on it. They don't so far. So your trauma is going to be a hands-on assessment and under trauma. I told you guys that you're going to do the head-to-toe assessment with your head-to-toe exam. So checking the head. Whenever whenever you're doing this, you're looking for here's a mnemonic: DCAP, BTLS. And don't even ask me what each one of those mean. That came after I went through even paramedic school. So it's deformities, crepitus. But if you find DCAP, BTLS, it'd be a good thing to remember. But basically, whenever you're assessing the head and airway here, you're checking for any. Dang, what the heck is that? What's Leedy doing to our camera?
My mom.
Putting a monitor together.
Yep. So, all right. So, there we go. I got it back. You guys notice what happens there whenever somebody else talks, it flips their screen. So you're looking for any bruising, any lacerations, like any bleeding. Any deformity, any crepitus. You guys know what crepitus is? Crepitus is when two bone ends rub together. It's a feeling. Look in the eyes. Make sure that your eyes are present, obviously. Pupils are equal and reactive to light. Pearl, they also have pearl. Look at the nose. Make sure that you don't have any blood coming out of the nose. Open the mouth. Look at the mouth. Make sure you don't have any obstructions in the mouth, no broken teeth, anything in the airway that you need to suction. Guys, and understand that whenever you do a head to toe, it's going to be very quick, okay? It's not going to be something that you're going to be like, okay, I don't feel anything. You're going to look in the ears, see if you see any blood coming out of the ears. Whenever you go down, check the neck, see if you feel any step-offs on the neck, basically where the spine is uneven. The only step-offs I've ever been able to feel is when their head's on crooked and they're not breathing anymore. So if that's a severely broken neck, I have never felt somebody that is conscious of talking to me, something that I felt was a true step off. Just kind of FYI. Look at their trachea, that thing that sticks out there. See if it's deviated to one side or the other. Typically a late sign if you have a pneumothorax, but but if you notice that it's just not straight and in line, note that. See with their jugular veins, if they look normal, if they look all puffed out and distended or flat. You move down, you're going to check for any crepitus in the shoulder girdle. Check your chest, make sure you got equal expansion and excursion, or rise and fall. You're not listening at this point in time. You want to come down, check your abdomen, make sure it's soft and supple, non-tender, no masses that you're able to palpate. Check the pelvis. Guys we used to rock the pelvis pretty hard. Don't really do that anymore. You might end up causing more injury than you need to. Just check for pain and see if it feels unstable. But don't do the big squeeze in and then push down on it, and you'll still see medics do it. It's because we learned it a long time ago. But if you go and you just kind of palpate on the pelvis and they wince in pain or they complain of pain, then that's good enough. From that point, you want to go down, you want to check your lower extremities. Make sure that that you don't have any fractures, they're in line, and then check your upper extremities. Do a quick pulse check, make sure that there are pulses present in them. If you could feel it, I wouldn't waste a lot of time looking for it. So neck, chest, abdomen. Oh yes, and I forget. Check the back. They're showing a check in the back here. Guys, I would hold off on checking the back until you're going to log roll them onto a long spine board, okay? No sense in moving them to check the back, just have to move them again here in a minute. All right? Checking the pelvis, checking the extremities. So head to toe examination factors can cause difficulty, confusion and excitement, fear or denial, altered mental status, disabilities, heavy clothing, distracting injuries, and age. So all those make sense, right? So altered mental status. Guys, I'll tell you what. Some of your head injuries are the strongest friggin' fighting people you'll have. You think it's real easy to do a head to toe on a patient that's fighting you, especially if they're most scared they ever are in their life? No, it's not easy at all. So, and then heavy clothing. You need to go ahead and expose, get those clothes off so you can do a proper assessment. So he's evaluating the elbow. Right? Yay, go elbows. Vital signs. Baseline set of vitals are going to come after you determine the severity of your patient, okay? So your baseline vital signs are going to be pulse, respiratory rate, skin color, temperature and condition, and pupils. And then reassessment. Guys, you're going to reassess on a critical patient every 5 minutes is what the state says, and every 15 on a non-critical patient, okay? I'm going to be honest with you here just for a minute. If I'm checking my baseline set of vitals every 5 minutes, I'm not doing anything else but checking vitals. So, yes, you need to check them, reassess them, and reassess them often. And remember that 5 minute thing, but in reality, 5 minutes is a little too close together. So. There's a lot of pictures. Reassessment. They didn't go over, and maybe I'm going to wait, but if they don't, I'd really like to go over OPQRST history tonight. Reassessment, primary assessment, vital signs, patient complaints, and interventions. After you do an intervention, you want to go ahead and go through and do your assessments again. You want to see if it helped or hindered your patient, right? So another thing is, we got heartburn. Another thing is you start to see trending in vitals. Remember, we're talking. Goodness, I'm dying over here. We're talking about compensated shock, where we had this blood pressure that was in the normal range with this high heart rate. Well, if the heart rate stays high and that blood pressure starts to drop and drops below a normal range, we know that our patient is becoming less stable, right? They're kind of circling the drain. Or we also could know if their blood pressure stays the same and their heart rate drops into a normal range. We also have a pretty good idea that they're just anxious from what happened, right? So yes, we still want to keep an eye on them, but you want to watch the trending of your vitals. So make sure that your interventions are working and things like that. Patient is in considerable distress and unstable. You update responding EMS personnel. Patient is worsening. And let me go see what we got here. I just want to make sure I didn't really miss anything big as we're doing this. So in the book you have, you approach the patient and he is, as you suspected, in considerable distress and unstable. You update the ambulance immediately and begin caring for the patient's ABCs. The patient appears to be worsening before your eyes. His level of responsiveness has dropped considerably. You are concerned that his breathing may be inadequate and prepared to ventilate the patient. Will you be able to do a secondary assessment for this patient? Why or why not? No, yeah, good. No, you're not. Why? Because we're addressing the primary problem, airway, breathing, circulation, right? So, good answer. How would you care? How would you care change? How would your care change if two coworkers heard the call and stopped by to help?
One could do, I guess, a secondary assessment while you're addressing the issue.
Yeah, or there are EMRs. One of them can take over the bag valve mask while you go ahead and you look for additional injuries. Go ahead and carry out your secondary. The big picture, the big picture. Let me see if these guys, and I'll send out these slides to you guys tonight if you want to read the big pictures. I'll make sure that we're not. Oh, hey, look, review. Should we take our time and just go through?
Yeah, sure, if you don't mind.
It's all right. I'm going to go ahead and hit this review because I see a few things I didn't go over. I'm confused by how the layout of this chapter is and the fact that they didn't even talk about the OPQRST history on the slides. So OPQRST history consists of onset, provocation, quality, radiation, severity, and time. You will want to, and I think it's going to be in, it has to be in here somewhere. I hope.
It was in the next chapter, I think.
Is it in the next chapter?
I think it was.
You're not yanking my chain, are you?
I thought I seen it in here.
Uh-huh. So, OPQRST history will be how you do your secondary assessment on your medical patients. And you'll gear that questioning towards their illness. So
OPQRST?
Yep.
Yeah, it's on page 268. We went past it.
Did I really?
Oh, we got two chapters.
Yeah.
All right. Hey, 268 is OPQRST history. Thank you. And that was in the last chapter, huh?
Yeah, right after sample.
Yeah. I don't know why they didn't have it in the slides. Please no sample and OPQRST history. It'll help you a ton. All right. So secondary assessment. Define secondary assessment. Somebody, anybody?
Secondary assessment is when you check in again.
Okay, so then observation. A secondary assessment is a second investigation to systematically address the patient to determine what else may be wrong. So observation. Observation is assessment findings found by direct visualization, right? Easy enough. What's auscultating? Yeah, good job. Listening to your ears, that's good. Palpating.
Feeling with your hands.
Yeah, assessment findings found by pressing on body areas. And how are you doing that with your hands, right? What's a distracting injury?
From something else could be more serious. Scraped ankle compared to dizziness.
Yeah. Injury to one area that masks a more serious injury due to increased pain. Manual stabilization. We didn't really go over that much.
To stabilize the head.
Yeah, so manual stabilization is if you're suspected a C-spine injury, whenever you're doing your initial assessment, you're going to take inline manual stabilization. So you're going to hold the head in that inline position, okay? And then you're going to do your assessment. You don't put your C-collar on that until you're secondary, right? And then asymmetry. Unevenness, yeah. So
that can be in your chest.
yeah, and I showed you guys an example of a flail chest, which is a chest, it's asymmetrical, right? Sometimes you could even have just a fractured chest where just one side's going up. Maybe they have a complete collapsed lung or something like that, or maybe they had a lungectomy or their lung removed. You'll get an asymmetrical chest rise with that.
Would that be considered a stroke too, to a point, because if the face is.
Yeah, you'll have an asymmetrical smile in a stroke. Yeah, good job. So what's a stoma?
Stoma is where they got the.
Yeah, it's a hole in the neck, right? Where they.
Tracheotomy.
Yeah. So that's one thing that you're going to be looking for whenever you're assessing the neck. Lateral recumbent.
Oh,
That's no, it's not.
No, it's lying. That's like you're lying on your side. Yeah.
Lying on one side. Good job.
Yeah.
Cognitive disability.
Patients with disabilities.
Well, it's, they're
You got it.
impaired thinking.
There it is. Impairment of thinking. Good
All
job.
that has to do with the brain, I know that.
Reassessment.
That's going back over your assessment.
Yep. Strategic ongoing assessment of the patient's condition and your interventions until the arrival of EMS. Trending. I talked about trending vitals.
You on YouTube.
Yeah, what's trending on you? Same thing, right? So you're watching those vitals to see if they're going up, if they're trending up or trending down, right? So you're watching the trend of the vitals. So, all right, primary assessment focuses on immediate life threats, while secondary assessment focuses on yes, go with it.
Huh?
Yeah, go with it.
All the above?
Yeah, D. Good job. Go with it. Own it. The trauma patient usually will benefit from the assessment findings revealed in Head to toe. Good job. Head to toe, guys. After assessing the head using the DOTS mnemonic, you should next observe the blank using the same method. Nick, yeah, good job. Obvious, right? Oh, come on. There you go now. What does the mnemonic DOTS stand for?
Deformity, open injury, tenderness, and swelling.
That's why you use it, because you're using it on as you're doing your assessment. So makes it easier than all the things I said, right?
Especially if they got a leaked out stomach and all that.
When would the EMR not be able to complete a secondary assessment?
If you're by yourself, when you're addressing an airway or something.
Yeah, whenever you're addressing a life-threatening illness or injury or and you're by yourself. Good job. What is discuss the steps of a secondary assessment of a trauma patient? Basically, what are we using to do our secondary assessment of a trauma patient?
Another person.
The head to toe, right? Detailed head to toe assessment. So you're gonna start at the head, work your way down to the toe. So. All right. So we will get through 13 tomorrow night, and we'll start studying. We will not go into another chapter until till Monday. So, tomorrow 13 will be the last one.
Even if we like study a little bit more, take our test like Wednesday, you know.
Whoa.
Yeah.
Damn, wow. Damn. He knows what done. He's getting ready to go home and have food, so hey, he's ready to jump ahead.
So yeah, go ahead and if you can tomorrow, go ahead and read your chapters and stuff like that. And any questions, lady?
No.
Did the new student, if she started her test, or is she going to do it tonight at home?
She's gonna do it at home.
Okay, I'm going to go ahead right now and send out the YouTube link so that everybody has that. And I sent her the link for the test. So have her get a hold of me if she doesn't get that. Okay.
Okay.
All right. Have a good night.